Good morning, good afternoon, good evening, and welcome to this second session of our workshop series about bubble activities for therapeutic ultrasound. We had a fantastic first session last week about passive cavitation detection and equipment and calibration. This session has been recorded. The recordings are available on our website together with a summary of the panel discussion. Today, we're going to discuss cavitation mapping, and imaging. The session will be moderated by Kevin Haworth and Michael Gray. In terms of logistics, so just to remind you that you have the Q&A panel to ask questions, and we encourage you to ask questions during the presentation so that they are ready for the speakers. The session will be structured around presentation, 15 minutes presentation, followed by 5 minutes of questions. We'll have a 10-minute break, and then we'll resume for a panel discussion. And with that, now Michael Gray will introduce you to this session.
Hi, everybody, and welcome to session 2 on cavitation, localization, and mapping. My name is Michael Gray, and I'm a senior research fellow at the Biomedical Ultrasonics, Biotherapy, and Biopharmaceuticals Lab, also known as Bubble, here at the University of Oxford. Let's keep things moving now and turn it over to my co-moderator, Kevin Haworth.
Great, thanks, Mike. It's my pleasure to moderate this session with Mike. My name is Kevin Haworth. I'm associate professor at the University of Michigan, University of Cincinnati. I went to the University of Michigan. That's a weird comment. Anyways, we want to go ahead and thank the Focused Ultrasound Foundation and the AIUM Future Fund for sponsoring the session today and the workshop overall. We also want to acknowledge not just the speakers and panelists that we'll have today, but really all the attendees watching, because we do feel that those questions that you'll be contributing during the session are critical to the overall goals of this workshop. As mentioned, we're going to be building on the session from last week. We'll be moving from hardware and software into talking about creating images and understanding how we might use those images for guidance and monitoring of therapy today. Our overall primary goals are to provide an overview of the field and develop some consensus, hopefully, on what topics are resolved and also what topics do we need to study further. To get us started off with that, we'll have 5 speakers. The first will be Konstantin Kusias from the University of Oxford, who's going to give an overview of cavitation, localization, and mapping. That'll be followed by Megan O'Reilly from Sunnybrook Research Institute on cavitation mapping for transcranial and transvertebral applications. Jonathan Sukovich will then talk from the University of Michigan on active and passive mapping in histotripsy therapies. Julianna Simon from Pennsylvania State University will talk about monitoring kidney stone therapies and deep vein thrombosis applications. And we'll end the session with a talk from Costas Arvanitas from the Georgia Institute of Technology on feedback control methods for microbubble enhanced ultrasound therapies. As Fred mentioned, following each of the speakers, we'll have a brief Q&A session, and we encourage you to type your questions into the chat box, as mentioned, during the talks, so people have a chance to upvote them, and then Mike and I will pose those kind of most popular questions to our speakers. And with that, I want to go ahead and move into introducing our first speaker, Konstantin Kusias. Professor Kusias received his PhD from the University of Cambridge before coming stateside for fellowships at the University of Cincinnati and Boston University. Thereafter, he switched to the rival team and joined the University of Oxford, where he established what is now one of the leading therapeutic ultrasound laboratories in the world, the aforementioned Biomedical Ultrasonics, Biotherapeutics, and Biopharmaceuticals Laboratory, otherwise known as Bubble. He's currently a statutory professor of biomedical engineering and the director of the Oxford Institute of Biomedical Engineering. He's founded 3 biotech startups, has won numerous awards and fellowships, and amongst the many, many contributions he's made to therapeutic ultrasound and other areas is cavitation mapping, and that's what we will hear about now.
Hello, I'm Konstantin Kusias from the University of Oxford. Thank you for the opportunity to introduce passive acoustic mapping for cavitation imaging. Many of the lectures we heard last week focused on single element passive cavitation detection as a way of characterizing cavitation activity in tissue. This consists typically of a single element focused ultrasound transducer and a single element cavitation detector that receives the acoustic emissions emanating from the focus. This type of detector scheme can, of course, classify bubble activity into inertial or non-inertial, but can only detect bubble activity on axis. And it can only reliably localize the earliest cavitation event that usually appears as an onset in the acoustic emissions recorded by the trace. But beyond that, it is no longer capable of distinguishing between coaxial cavitation events and their respective durations. That brings the topic of array-based cavitation imaging as a possibility. And a logical next question to ask is why not use B-mode in order to characterize cavitation activity? There was a series of studies done between 2004 and 2007 investigating synchronous exposure of tissues and tissue mimicking materials to both B-mode and single-element passive cavitation detectors. The passive cavitation detector signal is shown here in black, and the earliest onset of B-mode hyperecho is shown here in red. And what these studies showed in various shapes or forms is that it was perfectly possible for substantial cavitation to exist long before it ever became apparent on a B-mode image. In other words, B-mode images can only detect bubbles that have been generated and are stable enough in the tissue in order to be able to generate enough of a reflective signal to result in a change in hyperecho. This naturally created the need for multi-element or array-based passive acoustic mapping of cavitation activity as a possible way of being able to localize therapeutically relevant cavitation. Most ultrasound-guided systems consist of a single-element ultrasound transducer with a coaxial B-mode imaging array through the center. And typically, those are chosen in such a way that the center frequency of the diagnostic array is significantly higher, between 3 and 10 times higher than the center frequency of the focused ultrasound transducer array. As the therapeutic array generates a large enough signal in the target, bubbles respond to acoustic excitation and generate acoustic emissions which are simultaneously received on all 128 elements of the linear array. Passive acoustic mapping then makes it possible to recreate a map of the location of these sources of acoustic nonlinearity in real time. Therefore, what is passive acoustic mapping? Well, it is a method for localizing sources of sound that relies on coherence metrics applied to passively received signals across several detectors. And this is very important. It is fundamentally different to pulse echo imaging, in the same way that a bat uses a very different way to detect a signal than the human ear knows how to localize a source. We are actually, as humans, receiving a simultaneous signal that is sensed by both ears. And we know by virtue of the relative difference in time of arrival whether that source is located to the left or to the right-hand side of our head. It is exactly the same principle that is applied here for passive acoustic mapping. And this type of technique can be operated without any prior knowledge of the signal or energy form that caused the sound source. And we do not image the mere presence of bubbles, but only in fact those bubbles which are active in the therapeutic sense and therefore exhibit nonlinear behavior, either non-inertial or inertial, and produce secondary acoustic emissions. The birth of passive acoustic mapping started sometime around 2008, when a series of studies were conducted that demonstrated the feasibility during therapeutic ultrasound exposure of actually reconstructing these acoustic emissions. And this reconstruction was typically done either in the time domain or in the frequency domain, using early work that was either coaxial with the ultrasound beam or transverse with the HIFU beam. And there have been 2 or 3 very significant evolutions through this. The first was the first realization of the ability to map cavitation activity in this way. The second was the advent of frequency domain techniques, which I will describe in further detail later. And the third was actually a new generation of algorithms that either greatly improve spatial resolution or significantly decrease computational time. The basis for passive acoustic mapping was an algorithm that has become known as time exposure acoustics. This was inspired by seismology, where it was actually used to identify the origins of earthquakes beneath the Earth's crust. This was adapted into a technique for localizing nonlinear sources of acoustic emissions, particularly broadband sources at the time, in any location in a 2D grid as a function of the distance from any particular voxel to the sensor. From the received data, the source strength is measured for that point in the voxel using the equation shown. And that term includes the piezoelectric efficiency of the sensor and compensation for spherical spreading. And for a collection time period of time t, the energy for that same point in the voxel is given by this equation and enables us to obtain an answer in joules. Therefore, looking at some of the differences and similarities between active mapping and passive acoustic mapping, or B-mode and PAM, it is clear that pulse echo requires interlacing with a therapy pulse, whilst PAM can only operate during therapeutic ultrasound excitation. We need to localize and map based on time of flight information in B-mode, whilst we base it on source coherence metrics in PAM. B-mode is excellent at providing anatomical information and detecting the presence of bubbles, whilst PAM provides a very high SNR that is specific to high-frequency acoustic emissions, particularly those at a different frequency to the transmitted therapeutic ultrasound frequency. Two other very important points is that in the case of B-mode, both the axial resolution and the transverse resolution are determined by pulse length and point spread function respectively, whilst both are determined by the point spread function in the case of PAM. And the frequency resolution is primarily determined by the diagnostic pulse duration in the case of B-mode, whilst it is far greater in the case of PAM because it is determined by the windowing length and the sampling frequency. And of course, there is no reason to choose between these two techniques because they can coexist within the same hardware. So for the first time with passive acoustic mapping, we're now able to know not when something happens, but where something happens, as illustrated here in an early 2010 videos where three very different sources of acoustic emissions occurring simultaneously within an ultrasound field can be imaged, as can the revolution. This also makes it possible to distinguish between the time and frequency domain events on a spatial basis. In other words, it makes it possible to segregate the acoustic signature from a bubble at this location to the acoustic signature at the bubble in this location. And this opens a unique opportunity, again for the first time, to know what happens when something happens. In this video here from James Choi at Imperial College, we can actually see that depending on where we place our voxel of interest in the field, we can identify simultaneously existing different cavitation regimes that consist either of narrowband emissions only, non-inertial cavitation, or broadband emissions, inertial cavitation. A frequently asked question is what are the units of PAM? And I'm very grateful to Christian Coviello for providing this calculation. The units here demonstrate that the source strength squared is effectively got units of watts, and therefore integrating that normalized source strength squared over time yields naturally units of joules. It is therefore theoretically possible to convert these passive acoustic maps into energetically meaningful units. As mentioned previously, the spatial resolution of passive acoustic mapping is primarily dependent on the point spread function. And you can see it here expressed as a function of the F number and the wavelength. And you can see that it is possible to achieve pretty extraordinary transverse spatial resolutions. But axial spatial resolution is more challenging, ranging between 1 and 10 millimeters, depending on the distance of the acoustic source from the array. Great start as it was, there were also several limitations of time exposure acoustics PAM and several things that weren't accounted for. The first of these challenges was the coherence interference caused by multiple bubbles. And as we can see here, that gets progressively worse as the number of sources increases, creating a very noticeable tail artifact. The second is that TA was incapable of coping with variations in element sensitivity, such as that very dead element seen in this otherwise relatively uniform plot across 64 elements. Thirdly, the small receiving aperture and compensation for spherical spreading with a distance is a challenge. And also attenuation, variations in speed of sound, and the need to compensate for array diffraction all need to be accounted for. So let's start with the development for the first three of these problems. In around 2012-13, the idea of using adaptive beamformers instead of time exposure acoustics was first put forward by Christian Coviello and co-workers. And the value of this approach is shown here. Typically, in time exposure acoustics, every single sensor is given equal weight across all received channels, which means that in time delaying the signals relative to each other, there is actual equal amplification given to the primary source of interest and to any interfering sources. The key idea behind adaptive beamformers is that the weights on each of the channel are varied, which makes it possible to optimize those weights in order to maximize the coherent signal from the source of interest and minimize those from any interfering sources. As an example of the type of dramatic improvement that these adaptive beamformers can bring, here is the image of microbubbles flowing through a channel, which, as you can see, creates a very significant tail artifact with a sound coming from above. But that artifact is very significantly reduced and almost entirely removed with the use of the robust Capen beamformer. And in fact, going from time exposure acoustics to different types of higher order adaptive beamformers, all that really changes is the way in which this weight calculation is performed, going from a weight calculation of 1 for TEA to weight calculations that fit various constraints in order to maximize the coherence of the source of interest and minimize that of interfering sources. So how do those weights actually act on the signal? Well, for a signal that is immediately on axis, you can see that time exposure acoustics effectively applies the same weights all across, and there's relatively little variation in those signal weights applied by the robust Capen beamformer. However, if we move to a signal slightly off axis, time exposure acoustics still maintains a unity weighting across the channel, but there is now very significant variation of those weights across the span of the array in order to minimize that off-target source interference. Another significant set of limitations, as mentioned, are those of attenuation, variations in speed of sound, and array diffraction. I do not have the time to cover all of those, but here it is very important to realize the power of frequency domain techniques and data adaptive techniques that were developed shortly after the time domain techniques. And these frequency domain methods have huge benefits in terms of speed, as shown and demonstrated by Hayworth and co-workers and Arvanitas and co-workers, can provide much greater accuracy because you can use exact steering wheel delays and there's no need to upsample or approximate delays with integer sample periods, and is amenable to corrections for quantitative inputs such as diffraction and attenuation factors. So, for example, using frequency domain RCB reconstruction here, this is what we get in a non-attenuating waterpath. That signal is very significantly attenuated, but can then be recovered almost in its entirety by applying frequency domain attenuation compensation. There have been several more recent beamforming and processing developments, and this is a very rapidly expanding field, moving from short pulse methods to Doppler, to processing acceleration, to time window effects. And all of these techniques have yielded significant improvements in the time and the spatial resolution of TEA and RCB calculations. It is also important to point out that real-time systems for in vivo therapy have been developed that enable, through the use of GPUs, real-time reconstruction of passive acoustic mapping. And here you can see a prototype dual transducer system that has been specifically developed in order to enable 400 micron spatial resolution in both X and Y and less than a few millimeters in Z. I'm also very proud of the fact that these techniques are being increasingly deployed in clinical systems, and work being done by extraordinary engineers within these companies have now made it possible not only on GPUs, but on CPUs to calculate as many as 5,000 voxels in less than 70 milliseconds, making it possible to create very, very significant and impactful fields of view to monitor therapeutic treatments. In finishing, I would like to thank the fantastic team of co-workers, and particularly the top row here, Dr. Mike Gray, Dr. Christian Coviello, and Dr. Miklos Kyongi, for the very significant contributions to this presentation, and also the numerous colleagues across academia and industry who have made it possible to assemble this talk. In conclusion, passive acoustic mapping presents some extraordinary opportunities to image and classify cavitation activity in 2D and 3D. And these ever-improved beamformers and computational optimizations make real-time PAM a possibility. However, challenges remain in terms of calibrating PAM arrays, correctly incorporating the impact of attenuation, speed of sound, and diffraction, achieving a large enough aperture in humans to achieve adequate not only transverse but also axial resolution. And later in this series of workshops, we will be asking ourselves, what do these PAM color map means, and are they energy preserving? Cameron Smith will be talking about this in next week's workshop. Given this capability, much work remains to relate PAM-derived cavitation doses to bioeffects, and I hope several teams here will be inspired to take this work forward. Thank you.
To go ahead and type them into the Q&A section there. I'm wondering to start off with, if we can get you to pull your crystal ball out. You talked about there being a couple of major waves that have occurred when you were on that history slide. What do you think might be the next wave that we're seeing with PAM?
That's a really good question. I think the next challenge will be techniques that enable all of us to map cavitation activity in a consistent way across labs and report our results in a manner that is energy preserving and therefore replicating real units irrespective of what system you're using. And I think the second revolution we're waiting for is enough of an advance in the computational efficiency, but also the transducers, so that we can actually do this in 3D and reconstruct volumes rather than segmented planes.
Fantastic. And I'll use that first wave that you kind of talked about there with respect to energy to ask my next question for you, which is, you showed that, we can certainly resolve individual microbubbles. You also showed that, we can report these units in terms of joules and energy. What do you think that means when we've got something like histotripsy, or when you have a relatively high density of exogenous nucleation agents, where you're really talking about cavitation clouds instead of individual microbubbles?
I think we need to accept that the inverse problem is not fully resolvable, and all we can ever really quantify is the energy radiated from a control volume surrounding the bubble cloud. Quite what happens inside that bubble cloud is lost to us forever. I think what we can hope, however, to achieve, if we can quantify that bubble cloud energy, is that in specific applications and in specific media, we might gain enough intimate knowledge of the bioeffects and the likely bubble density that we could draw more meaningful conclusions than we currently can. It will never be perfect, and frankly, very few medical monitoring technologies are. And they hopefully will provide a better and more quantitative guide to delivering safe and effective therapeutic ultrasound treatments.
Fantastic. And one last question, I think a relatively quick one from the audience, which is, are dedicated imagers required to do PAM?
That is a technology that is changing incredibly fast. And I think as we are seeing the advent of advanced processors, even that sit on probes, any technology that can give you access to a sufficient number of raw RF data can actually enable you to reconstruct PAM. And so I think in the not too distant future, we will see this become a very low cost technology with onboard processors that could almost be plug and play in its most basic form.
Fantastic. Thank you. And with that, we'll need to wrap up this one so we can stay on time, but please do stick around for our panel discussion later. With that, I will turn it over to my co-moderator, Mike, for our next talk.
Thank you.
Thank you, Kevin. It's my pleasure to introduce Dr. Megan O'Reilly. Megan is a senior scientist and Canada Research Chair in Biomedical Ultrasound at the Sunnybrook Research Institute, as well as an associate professor in the Department of Medical Biophysics at the University of Toronto. Megan is a leading innovator in the development of systems and methods to deliver, monitor, and control ultrasound therapy in the brain and spine. And we're very happy she's here today to present a talk on these exciting areas.
Hi, I'm Megan O'Reilly, and today I will be trying to cover in just 15 minutes some of the material that's been done on localization mapping and quantification of bubble activity in both transcranial and transvertebral applications. So, as for other applications, we have a common need for localization mapping and quantification. We need to determine the location of bubble activity to assess if we're on target versus off target. In the case of the skull or the spine, we need to know if we're inside the bone or outside the bone. We may also want to localize bubbles for other applications, for example, for bubble-based focusing, and I'll talk about that later in the talk. And finally, we are really interested in moving from just localizing to spatially mapping in order to correlate with bioeffects. And so we need to, from these maps, be able to establish spatial extent, as well as somehow quantify the amount of activity. And of course, we're doing that in the context of going through a bone layer. So I'd like to start by just talking about what can we do with one, a few, or many receivers and working up in complexity before talking a little bit about skull-specific and spine-specific challenges. So it may seem that with a single receiver, there's not a lot that we can do in terms of localization, but there was a very nice paper from the group in Paris. The first author is Guillaume Membourg, from 2018, showing that we can actually capitalize on the frequency-dependent attenuation of the skull bone. And so here in this image, we see during blood-brain barrier opening, free propagation in water is the spectra shown in black versus the baseline signal in gray. And then in B, we see propagation through a non-human primate skull, and finally in C, through a human skull. And when you look closely at the ratios of specific harmonics, so in this case, they have the second and fourth harmonic, so the fourth harmonic over the second harmonic, or the 5 seconds ultra harmonic over the subharmonic, you see that you can get these ratios. And so compared to free propagation, there's only a modest change in the harmonic ratio in monkey skull, but there's quite a substantial change in human skull. And for the ultra harmonic ratio, we see significant changes in both. And this allows them to actually use this as a predictor of whether or not the cavitation is occurring intra or extracranial. And so you can see with the harmonic ratio, the red line is human skull, is very predictive, slightly less so with the primate skull, but in both cases, the ultraharmonic ratio performs very, very well. If we move up in complexity, we can look at now what we can do with just a few receivers. So here we have this 3-hydrophone method that was proposed by the group at Labto, and this is work from Maxime Lafont. And we can see that we have here 3 receivers being used to localize cavitation. And this is not done through skull, but just directly measured in water or chicken breast. We can see an error on the order of a few millimeters. Recently, Hong Chen's group at Washington University, St. Louis, has shown that if you extend this and use 4 receivers, you can perform this localization through a human skull. And they found that when using only a limited number of cycles in your pulse, you can get an error just below 2 millimeters. But this deteriorates as you increase your number of cycles. So there are many advantages in going with limited system complexity. Here, compared to our binary localization, we can get some sort of localization of the cloud within a few millimeters. But of course, the disadvantages are that your accuracy deteriorates with increasing pulse length. So this may not be applicable for all treatments. And once you have multiple sources that require detection, you now need to space out your sources on the scale of 1 to 2 times the pulse length. So again, this really works best for very short pulses. So when we move up in complexity, we can see work here with linear arrays from Costas Arvanitas when he was at Brigham and Women's Hospital. And here they've really nicely integrated a linear array with the Insightec helmet in order to enable passive mapping with the clinical device in non-human primates. Recently, we saw last week from Elisa Konakaigu's team at Columbia that they're now actually using linear arrays in their clinical trials as well for doing passive mapping. If we want now to go again increasing complexity, we could move to these large aperture 2-dimensional arrays that enable 3-dimensional imaging. And so these are typically custom built by the individual labs. We at Sunnybrook have been working for a number of years and have iterated through many prototypes of these. This is one example from a paper by Ryan Jones in 2018, showing one of our devices with 256 element units, each of which contains nested elements that operate at different frequencies, allowing you to transmit at one frequency and receive on one of 2 possible other frequencies. And we can see that this results in a very tight focal spot when we're generating our passive maps. Similarly, the team at Michigan has developed a very nice transcranial hemispherical array for doing histotripsy. And we can see here they're using their acoustic cavitation emission imaging in order to generate these maps of the bubble clouds. And I'm sure that we will hear much more about the applications of mapping in histotripsy from Jonathan Sukovich in the next talk. And then finally, I would just like to point to this example. So the other 2 devices were entirely custom made, both on transmit and receive, but the group at Brigham and Women's had a really nice solution to integrating an array with the Insightec dome. They built a sort of minimally interfering receiver array that could be placed over top of the Insightec device. And this allowed them to generate passive maps. So one of the challenges specific to skull and specific to spine is the need to do phase correction. And while the aberration is certainly less at lower frequencies, there's still a couple motivating factors for correcting, even if you can roughly get a map. And a key one is being able to accurately quantify the amount of cavitation. If without correction, we won't be able to get any sort of accurate estimates. And even in the minimally aberrated case, there tends to be some sort of focal displacement. So certainly there are advantages, and there are multiple approaches that have been proposed for phase correction. So the first one that was demonstrated was using CT-based correction. And you can see here's a water control case propagation through human skull without correction, source-based cavitation correction, and then CT-based correction. Scanning over a volume which contained a tube phantom, we see that without correction, we get a very distorted image of that phantom. But using either an invasive source-based correction or a CT-based correction, we're able to correct the maps generated through human skull. So an alternative approach, if not using CT-based correction, would be to use a bubble-based correction. And this sort of builds on an idea that was proposed by the group in Paris. The first author of this paper is Jérôme Gatteau. And they suggested that you could use a cavitation bubble signature and record that on your array of transducers and time reverse the signal in order to focus back. And so the idea was that you could do this for transmit focusing. And we've seen this idea now implemented by Incytec in their clinical device and tested in patients. And so there's 2 recent studies describing the clinical use of this sort of auto-focusing type approach. We used a similar method to correct on receive back when we were looking at super resolution ultrasound through the skull. So if you have a single bubble, or you can assume a point scatterer, using both the delays in the received emissions and an initial estimate of the location of the bubble, you can then extract the skull delays and use them to correct the passive maps. And so you can see we were able to generate nice maps of a spiral phantom through human skull after non-invasive correction with bubbles. So another challenge, and this is really not specific to skull, but I think a challenge that the field faces in general is understanding how much data is enough. How much do we actually have to capture in order to accurately represent the treatment? And so this is an issue because there are, of course, limitations in hardware in terms of buffer sizes, transfer rates, et cetera. And so that can limit how much data we can actually capture on receive. We see here, this is a recent paper from Ryan Jones at Sunnybrook, showing that if we are only receiving a small portion of the signal relative to our transmit time, if we reconstruct that, we see in the red, reconstructing 1% of the transmitted signal, we actually underpredict in some cases, overpredict in other cases, and get false positive regions of cavitation in our maps. Whereas if we can actually capture all of the cavitation emitted by capturing at least the length of the transmitted burst, now suddenly we actually are much better able to represent the therapeutic effect. And so this was sort of the first paper that looked beyond a capturing on the order of a couple hundred microseconds and actually captured a full 10 millisecond burst every cycle during this non-ablative, non-thermal brain ablation. So this was really the first paper that looked at not just capturing a few hundred microseconds, but capturing the full 10 milliseconds of each burst during non-thermal brain ablation mediated with bubbles. And this is sort of supported. This next paper is not a passive mapping paper, but is a blood-brain barrier study in non-human primates, showing something that we, and I'm sure others have also observed, that the bubble behavior really can change drastically within a burst. And that it's not always the greatest bubble activity at the start of the burst. There's potentially coalescence, growth, other factors that might bring bubbles to resonant size or destabilize them, as Benoit Larat's group is proposing. But we see here that several milliseconds into the pulse, the cavitation activity actually increases substantially. So if we're only capturing a small window of data within a longer therapeutic exposure, we might really not be imaging what is happening in the therapy. We may have very poor correlates to our bioeffects. Very briefly, my group has been looking at how we can do some of this work in the spine for imaging therapy in the spinal canal. And so we have additional challenges. There's the proximity of the target tissue to the bone, which is also relevant for some skull targets, even though a lot of the work to date has been done very central in the brain. Certainly when you get close to the bone, things become a lot messier. We have a high probability of cavitation events in the prelaminar region. And this means here, if we have 2 events occurring outside and 1 event occurring in the canal, for example, when we reconstruct these maps, we won't see the one in the canal unless we can account in our model accurately for losses through the bone. And then we have an aperture that's limited by anatomy. And so we can't use the nice hemispherical geometry that we have for skull. And so we're working to address some of these challenges. So for want of time, I really only covered clinical scale work being done in transcranial passive acoustic mapping, but there's a wealth of information in small animal models as well. And I'm happy to answer questions related to that. I think in terms of unresolved challenges, quantification in my mind is probably the biggest. Accounting for skull losses, accounting for receiver sensitivity. We often go with a more sensitive receiver, sacrificing bandwidth. And then of course we lose spectral content as a result. That might be very informative. And then there's the huge unanswered question of what is the best metric that relates to a specific bioeffect and how do we quantify that? And I don't know that we'll get the answer next week, but we'll hopefully get a little bit more information on this when we talk about thresholds. And then finally, as I alluded to, with just the sheer volume of data, the hardware limitations, and beamformer speed, and being able to beamform large volumes at a real-time rate to have this be very useful in therapy. I think, we're not quite there yet, but things are improving. Maybe this is a great opportunity for AI, but there's certainly some unmet needs there. With that, I'd be happy to take any questions.
Summarizing all the fields that you cover in 15 minutes is a challenge by itself. So my first question for you actually is, would you like some more time?
I would like more time. Yeah, so I don't know. It's a huge topic. And I think there's certainly a lot of the same challenges that we have just generally in the field. Like, how do we quantify, as Constantine mentioned, really at the best we can sort of get the energy radiating out from a volume, but we can't understand what's going on inside. And I think the bubble dynamics that can't be resolved within that bubble cloud can be really important. So in my mind, there's huge problems there. But I think we've made really great progress, and there's a lot of work being done, and it's very exciting. So I don't doubt that we will continue to see increased implementation and development on the transcranial work, and I imagine that the path forward will be that at some point passive mapping, passive imaging will be an integral part of clinical systems.
Great, thank you. We have some audience questions. I think we have time for one at this point. When using intracranial cavitation for phase correction, is there a particular type of cavitation that's considered or needed?
No, so I mean, obviously it's better if you're not doing inertial cavitations so that you avoid damage. You just need a distinct signature. So when we have done it for beamforming on the received data, we actually diluted the bubbles down so that we were only getting a single bubble at the focus. And so you really do get that point scatterer. But in the work that's being done now with the echo focusing in the clinic, the bubbles are certainly not that dilute. So you basically need to be able to resolve those as unique time domain signals And certainly that can be just from the harmonic content distinguished, and then be able to time reverse those or cross correlate them and extract delays from that.
Okay, great. Thank you. There are a lot more questions, but we have to continue. So thanks again, and please do stay on for our panel discussion later this morning with our featured guests, Dr. Catherine Ferrara and Dr. Joan Vidal-Gervais. And now I'll turn it back over to Kevin.
Great, thanks, Mike. So our next talk is going to be given by Dr. Jonathan Sukovich, who received his PhD from Boston University, studying cavitation in the context of physical acoustics. Then in 2013, he moved to the University of Michigan, where fortunately for our community, he transitioned into biomedical acoustics. His focus has been on a range of areas associated with histotripsy. These include advancing new applications of histotripsy, understanding the physical phenomena associated with histotripsy, and developing feedback and monitoring methods for histotripsy. And we'll now listen to his talk on that.
Hi, everybody. Thanks for having me. I'm Jonathan Sukovich from the University of Michigan, and today I'm going to be talking about active and passive cavitation, localization, and mapping, including for histotripsy. So as we've gone over in this workshop, there's numerous cavitation-based therapies, including microbubble drug delivery, sonothrombolysis, BBB opening, and histotripsy and its various incantations for doing ablation therapies. And these are targeted at a wide array of organs for various indications like brain tumors, liver cancer, breast cancer, kidney stones, etc. But if you're going to be doing cavitation, it's really important to do this localization and mapping to ensure that you're accurately delivering the treatment and for identifying the extent of it. And so there's various methods that you can use to do this localization and mapping. And I'm going to be talking about active and passive methods today. And starting with active methods, which rely on active acoustic interrogation of the target volume, usually using ultrasound imaging or pulse echo methods more generally. And so as far as active methods go, B-mode imaging is really, really great for imaging histotripsy-generated cavitation events because the cavitation events are really, really good scatterers of incoming ultrasound. And so you get these really bright, nice regions of bubble activity in these B-mode images that are just really easy to see. And so a lot of groups have demonstrated that. This is an example image from an experiment using boiling histotripsy to do melanoma ablation in a murine model. But we've also shown that in intrinsic threshold histotripsy, you can use B-mode imaging to evaluate bubble cloud generation as well. And this is an image showing B-mode imaging results of a bubble in brain tissue treatment. In addition to B-mode imaging, you can do bubble Doppler imaging, which is really well suited for monitoring transient bubble clouds. And in Doppler imaging, the idea is that instead of relying necessarily on scatter of the incoming ultrasound pulse from the bubbles, you're looking instead for chaotic motion generated by the nucleation and collapse of these bubbles, which generates these chaotic velocity fields. And so in color Doppler imaging or pulse inversion Doppler imaging, groups have shown that you can get an idea of where these bubbles are, localize them just based on this Doppler information. And it correlates well with observations from direct imaging of the same experiments. Another option for active cavitation localization is just to do ultra-fast active imaging. And so if you're doing B-mode imaging, you're kind of synced to the frame rate of your scanner. But if you want to capture the bubble immediately after it's nucleated, you can also synchronize the acquisition of your scanner with the firing of your histotripsy array. So synchronize the acquisition to the timing of the bubble generation. And so that's been demonstrated before as well, where they were able to show that they could localize and map or image these bubbles using this ultra-fast imaging technique and identify these bubbles kind of immediately after they were nucleated. And the results compared well with a passive beam-formed image of the same thing. But active methods have their drawbacks. So for B-mode imaging or really any of these ultrasound imaging, you have to have a clear acoustic path to the target in order to see it. So for instance, when we were doing the skull imaging or the imaging in the brain, we had to do a craniectomy to remove the skull to open that acoustic path. Another issue that you end up having is that the bubbles have to be large enough to be visible against the speckled background of the images. And so you kind of have to have a certain size bubble in order to do it. Another final issue that you see, especially for long pulse duration kind of treatments where the imager is aligned coaxially with the transducer, is that the histotripsy pulses themselves get picked up by the scanner and generate these giant imaging artifacts that can really negatively impact your ability to localize the bubbles. But in addition to the active methods, there's passive methods for localizing and mapping these cavitation events. And instead of relying on these active interrogation schemes, they instead rely on capturing nonlinear acoustic emissions from generated bubbles, including harmonics and subharmonics from stably driven bubbles, or broadband noise in the form of shockwaves from inertially cavitating ones. And the idea behind this passive localization and mapping is that you assume the bubble is a point source emitter, and en route to your receivers, the path that the emission travels between each receiver is different. So the arrival delays that you get are different. But if you can account for those arrival delays, you can delay them such that you can localize the bubble based on assumed sound speed measurements of the propagation medium. And so this is just an example of a bubble that's emitting these shockwave signals, broadband emissions at subharmonics of the frequency that it was being driven at. And you can see in the received acoustic signal down here that there's this periodic structure of these received signals at the subharmonic of the driving, as well as these signals themselves are just broadband shockwave signals. And a nice thing about these passive imaging techniques is that because the dynamics of the bubble are known, and we know that we're going to get subharmonics or broadband noise, we can frequency filter out the fundamental driving frequency of the incoming acoustic pulse, histotripsy pulse, to isolate the cavitation signal in order to localize it. And so in a typical passive acoustic mapping setup, you'd have your acoustic transducer here to generate a bubble in some phantom or some tissue, and you'd have your passive receiver next to it to record those broadband emissions and do the imaging localization reconstruction. And so numerous groups have been able to demonstrate the ability to do this, as I'm sure Konstantin has gone over. But what you see here is just an example showing the ability to passively acoustically map a series of 3 bubbles generated in the field just based on the time delays of the signal, or time delay of arrival of the signals at the passive transducer elements. Another interesting thing that you can do with passive acoustic imaging is actually calculate the total energy originating from that point in space based on the localization. So there's delay in some to get you the position of the bubble, but if you integrate over the received signals, you can get an estimate of the energy that was deposited in those regions and use that to kind of correlate with expected bioeffects. And so this is just an example showing a lesion generated in a stained phantom following exposure to cavitation, along with the B-mode images of where the bubbles were generated in that phantom, and this acoustic intensity map showing where damage was likely to be generated. And you can see there's pretty good agreement overall with where the damage was generated and predicted based on these acoustic passive mapping techniques. But going on to 3D localization and mapping, so far it's just been planar mapping. So you have these linear arrays of receivers, but for 3D localization and mapping, which is you have to do for transcranial applications, you need a 3D array of receivers in order to get the spatial information required to localize these things in 3D. And so a common technique for doing that is to embed a sparse array of receivers within your transmitter array in order to do these passive listening operations to record the signals you needed to do the localization. But it's also a little bit more challenging than that, especially for this application, transcranial applications like I'm going to be talking about going forward, because the skull is a really strong acoustic aberrator, which very much distorts the focus of your transducer, as well as your ability to localize bubbles generated through the skull based on the acoustic emissions. And just to give an example of what I mean, over here on the right, is a plot showing what the focus of the array looks like in the free field versus through the skull without aberration correction. And you can see it's wildly distorted. So it would be a really challenging operation to get good localization results out of that. And so in order to get good localization results out of that, you can do aberration correction. And so there's been a number of techniques to develop to do that. And one of the common ones for transcranial applications is based on CT measurements of the skull, from which you can calculate the skull sound speed, and then through acoustic propagation models account for effects of refraction or phase advances through the skull because of its different sound speed. And there's a bunch of software packages around for calculating these things that'll do it for you. In our group, we use Cranion from John Snell. It's really good for intrinsic threshold histotripsy, but there are more advanced modeling tools like K-Wave that could give you likely more exacting results. And so once you do that, once you correct for those aberrations, you can then start using those passive localization and mapping techniques to get good images of the cavitation events through the skull. And this is one of my favorite ones from Megan O'Reilly and Calero, showing super resolution images of bubbles through the skull. But I want to talk more now about intrinsic threshold histotripsy, particularly in relation to localization and mapping through the skull. And so one of the issues we have with intrinsic threshold histotripsy is that we can't sacrifice acoustic power in order to incorporate broadband receivers into this array. So this is one of the arrays that we use for transcranial applications. And the reason for that is because if we don't hit the threshold for nucleation, we don't get bubbles. And so there's nothing to localize. But since we can't do that, one thing that we can do is make all these array elements transmit and receive capable. So we can record the acoustic emissions from the bubbles using just these array elements. The issue with that is that these array elements are super narrow band, so we lose all of the frequency domain broadband information that you get out of hydrophones or ultrasound imaging arrays. But in intrinsic threshold histotripsy, an important thing to keep in mind is that the pulses that you're used to generate the bubbles are really, really short, so 2 acoustic cycles. So there's no scattering of that acoustic pulse off of the nucleated bubbles. Really what you get during intrinsic threshold histotripsy is the shockwave emission during nucleation and the shockwave emission from the bubble collapse. There's no scattering or anything like that. You're not exciting subharmonics. And to give you an idea of what these signals look like through the skull, here's just a representative example of a nucleation shockwave signal, a shockwave signal from one of the collapse events, and even the rebound of the bubble. After it collapses, it grows again, collapses again as a rebound. And you can see all of those things. So those were idealized signals. They're not always, so perfect and background free. The skull is a good reflector and reverberator of sound. But because it's stationary, you can just take a background signal, scale it up and subtract it from the super threshold signal where you generated the cavitation event to isolate the corresponding signal. And once you have that, you can project it back into the field to localize the bubbles doing volumetric image forming, something like that. And so we've demonstrated the ability to do that and localize bubbles to within an accuracy of about 1.5 millimeters. And when you generate maps of these bubbles, which you see here on the left from these projected acoustic signals, they correlate very well with the damage that you get in the volumetric target that is the brain over here on the right. But one of the things that we see often when we're doing histotripsy in volumetric targets is that you have to steer the focus to multiple locations. And when you do that, in addition to generating the cavitation event at the location that you want to, you end up re-exciting bubbles adjacent to it in the field. But those bubbles grow more weakly than the main bubble and collapse earlier. So as long as we can collect the collapse shockwave information, we can identify the presence of those bubbles. And that's what you see here. This is an example showing the received signal from every array element. This is the main bubble collapse event and its associated rebound ACE signal. And these stripes of signals out here are from these re-excited and recollapsing bubbles. And you can clearly differentiate them from the background. But the point is you can take those collapse information to localize those renucleated bubbles as well, in the same way that you can take the nucleation signal to localize the bubbles. And these were really just, in the lab, but we've shown that we can do this recently in the cadaver as well. And again, this is the wave fields from all array elements that shows the nucleation signal, as well as the collapses from multiple cavitation events, as well as the lesion that we generated in the cadaver brain. But some of the challenges still with these localization and mapping things is, overlying tissue is a big issue. If you wanted to do active localization and mapping of the brain, for example, you'd have to take the skull out, which is not something that you can reasonably do. 3D localization is also a challenge. If refraction puts your focus out of the plane of your imager, then you lose it. If you have to do volumetric image forming, it becomes a computationally very expensive task to do, especially for large volumes. Another issue is that not all cavitation events are huge, and you have to be able to detect these signals in order to do cavitation localization. So, sensitivity of your receivers is a really important thing to consider. Another big one is if all cavitation events were singular, it wouldn't really be a challenge to do localization. Even if there are multiple ones where you re-excite previously targeted locations, that's fine. But if you're trying to do like superficial cortical targeting and you have to monitor for cavitation events at the base of the skull, that's a big issue in terms of computational time. And this one is an opportunity, and it's partly in jest, partly true, is that if you're going to do cavitation, if that's the goal, then you can kind of just do it with intrinsic threshold histotripsy. And what I mean by that is that it's really great that there's all these algorithms for localizing these bubbles and picking out the needle in the haystack. But if you stop making the haystack in the first place, it's easy to find the needle. If you get rid of that acoustic background, the signal from the cavitation is easy to find. And it's come up whether we need calibrated measurements or not. And I don't know that we do. So the relative timings of those ACE signals is path invariant, and it's going to be the same on every single array element between the nucleation and collapse. And that absolute timing contains information about the cavitation energetics, which you can then use to inform on outcomes, biological outcomes. So worth thinking about. And with that, I'd like to conclude and thank everybody in my lab and open for questions.
Great talk. Thank you very much, Jonathan. Appreciate that. I want to quickly mention to all of our attendees too, because we had a number of questions we couldn't get to in some of the earlier ones. Mike and I will try to bring those up during our panel discussion. So please do continue adding those in. First question I have for you, Jonathan, is on the active approaches, and really this might also apply to segmenting passive data. How important is the timing of that interrogation? I mean, you showed, cavitation, components of the cavitation events happening in histotripsy over tens of microseconds or even larger time spans.
Right. So it depends, I think, on the type of histotripsy that you're doing. So for like boiling histotripsy, the cavitation event is going to live a little bit longer, and same with shock scattering histotripsy. So maybe it's not essential to get the timing right, but if you're doing low rep rate intrinsic threshold histotripsy, they tend to live on the order of less than a millisecond, where they're big enough scatterers of sound to, reasonably detect in at least B mode imaging.
Fantastic. Thanks. And next question I have for you, in Constantine's talk, he talked about, we kind of start with B mode and then we've moved to passive approaches, and there's no reason those can't go together. I'm wondering if you might comment on the potential to combine active and passive approaches that, you've described in this talk here. And does that bring additional value?
I think it does. I think it does a lot. So one of the things that I didn't really get a chance to cover is, if you recall that red plot that I showed, the yellow stripe on the left was the skull reflection plus the nucleation shockwave. So the skull reflection kind of dwarfed that nucleation shockwave and really just totally loses it. But, we can see the collapse signals in those, but that's not always the case either. So sometimes you do have background signals which make you lose all of it. So we've been experimenting a bit with firing interrogation pulses from the array and then doing basically false aperture imaging to localize those bubbles, where we can set the timing of that interrogation pulse so that it's outside of the background signal that masks the actual shockwave signal.
Gotcha. Very interesting. And then I think we've got time for just one more question here. In some of the histotripsy papers that have been published, it shows, exceedingly precise ablation zones, right? Where it's like half a cell is there, looks totally normal, and the other half is just entirely gone. So given that precision, what does that imply for the precision that we might want with our imaging approaches to monitor?
That's a good question. And I don't know that I have a great answer for that. I don't think you're going to get down to, 12 micron, half the size of a red blood cell kind of imaging, passive or actively. And, we've seen that damage generally conforms to the size of the bubble that you generate, but you're also generating some strain in the regions adjacent to it. So you might not be, tearing a cell in half, but maybe you're, doing some sort of minor damage in the adjacent regions that, you wouldn't capture from that imaging approach anyway.
Awesome. Thanks. Well, we have had a couple of questions just pop in on the Q&A, but unfortunately we've got to continue moving on in the interest of time and staying on time, but we will likely try to pose those to you during the panel discussion. So please stick around for that. And with that, I'll hand it to Mike for the introduction of our next speaker.
Thank you, Kevin. I'm pleased to introduce Dr. Julianna Simon, who is an assistant professor of acoustics in the graduate program in acoustics at the Pennsylvania State University, where she's also the recent recipient of an NSF Career Award. Her research has spanned a variety of topics in therapeutic ultrasound, including tendon healing, biomineralization, and kidney stone management in spaceflight. So we're very pleased to have Dr. Simon with us today to discuss these and other areas in the context of bubble localization and mapping.
Thank you for the introduction, and thank you for the opportunity to present in this workshop. My name is Julianna Simon. I will be talking about monitoring of kidney stone and DVT therapies. So kidney stones affect about 10% of the population in the US at a cost of over $10 billion annually. While most people think kidney stones are just a solid rock-like object, they're actually complex structures comprised of hard minerals held together by an organic matrix. And their structure is really defined by the conditions, the local environment as they form. If we look at, here's just a micro CT image of a kidney stone showing that we not only have the hard reflective type material, but we also have these dark voids within the kidney stone. If I looked at a different kidney stone, I could see very different internal structures. Now, kidney stones can form both in the collecting space or in the urine-filled space of the kidney, but also in the parenchyma or the tissue-filled space. They're usually innocuous while in the kidney, but become very painful while they pass. Kidney stones are most usually detected by plain X-ray, computed tomography, or ultrasound. Gold standard is computed tomography because we can accurately see the stone, size the stone, locate where it is within the system of the kidney, and be able to then develop treatments for it. Ultrasound is less commonly used because it has variable reported sensitivities and specificities, really depending on the skills of the operator. In the ideal case, the stone would appear as this hyperechoic region in a fluid-filled space with a posterior acoustic shadow. However, oftentimes they show up more like the case on the right, where we actually don't see any kidney stone in that field of view that's obvious. That's where the twinkling artifact comes in. So the twinkling artifact has been shown to improve the sensitivity and specificity to detect kidney stones. It's where the stone appears as this rapidly changing color, makes it very easy for non-expert sonographers to detect this kidney stone. The challenge is it only shows up about 60% of the stone. So I've been doing some research to try to understand that. And that's where we came up with this hypothesis that small stable bubbles may exist on and within kidney stones and cause the twinkling artifact. So if we look at a scanning electron microscopy image of a kidney stone, we see that there are very rough surfaces. And going back to Dr. Apfel's paper, surface tension will stabilize bubbles within these crevices such that when you change the pressure, you can change the concavity of the bubble, but there's still bubbles that are present and kind of stabilized on the surface. This was verified when we imaged 8 human subjects in a hyperbaric chamber. What we found was that twinkling decreased when the pressure increased. So pressures in blue, twinklings in red. And even more interesting, when it went to a different gas composition, oxygen, we found that twinkling significantly increase before returning to atmosphere. So this is evidence that there are bubbles on the stone in situ, which leads to some of our understanding of cavitation in kidney stone therapies. So kidney stones are treated with ureteroscopy, percutaneous nephrolithotomy, both of which are surgical options, non-invasive or minimally invasive or invasive surgical options. The other option is shockwave lithotripsy, which is where we'll focus here because shockwave lithotripsy uses cavitation and stress is created by the elastic wave to break stones. So here's just a couple waveforms. The HM3 is the original shockwave lithotripser device. The Storz is a newer shockwave lithotripser device. And we can see the amplitudes of those shock waves that are developed. Now, Pishnakolov has shown, and others have shown, that there are bubbles that appear on the kidney stone, both posterior and anteriorly, when the shock wave arrives in it and causes those bubbles to expand and collapse violently. That causes pitting on the stone surface, which when coupled with these elastic wave propagation and these tensile and shear stresses, these local maximums also work with the pitting to cause the stone to actually break up. Now, passive cavitation detection has been used for real-time evaluation of stone targeting in shockwave lithotripsy. This is out of the Leighton group that shows that this is a passive cavitation map. They found that certain metrics of this PCD can be used to evaluate how well the stone's targeted in the shockwave lithotripsy unit. So the first shock or the first signal that we're seeing is really the shock interacting and reflecting from the stone. Then we have some time before we see the bubble collapse and rebound. One of the metrics they found that was useful is looking at this collapse time. This is showing not only the interaction with the tissue path, but also the bubbles are theoretically supposed to expand during this time before they collapse. We also have these amplitudes of M1, that time for initial the first scattering from the shock from the stone, and the M2, which is the cavitation collapse rebound. And the ratio of those also can indicate whether the stone is well aligned. This is supported in their results that showed that this black box is kind of the ideal case of collapse time versus the M2 to M1 ratio. When we have more of those dots from each of the successive shocks, we get better fragmentation. So the image on the right shows we have a lot more shocks, about 70% of the shocks within this black box with 100% fragmentation, whereas the case on the left, only about 20% of the shocks are within the box and 0% fragmentation of the stone. PCD has also been used to monitor treatment progress. Energy changes from the frequency band or from one frequency band to another as the stone fractures. And this is related to resonant scattering of the stone. If we look at hydrophone measurements, we see the little bit of shock, but we see this oscillation after the shock finishes arriving. When it's fractured, we get a lot more oscillation in the signal, which if we do an FFT, we find that there's more energy in the 0.5 to 2 megahertz band as the stone works and starts to fracture. And again, that's just related to the resonant scattering of the signal. When we get the cavitation in the collecting system, that of course helps break up the stone. But in 2005, Mike Bailey showed that, well, we can also get cavitation in the parenchyma, and that causes tissue injury. And so here's just an example of cavitation in the collecting system. We get the hyperechoic, a very strong hyperechoic signal in this case. And that's great because that would work to break the stone. However, we also get it in the parenchyma. So if we just look at the image, we see the focus of the shock. When the shock arrives in part B, we get a lot more hyperechogenicity happening. We can do a PCD trace of it. But the challenge is, how do we separate out the good cavitation that breaks the stone from the bad cavitation that actually causes injury to the tissue? And finally, part of kidney stones is there's a group, Peizong's group, that's worked to do this active and passive acoustic mapping and looking at spatio-temporal distribution of bubbles. Basically, they compared a high-speed camera to active cavitation monitoring, looking at just the location of cavitation activity. This was just a simple delay in some active cavitation mapping. And then they also looked at passive cavitation mapping, modeling each bubble as a sparsely distributed point source, also compared to the camera, and then put it on a time map. And then this should make sense because the earlier time would be active cavitation mapping. Basically, whenever you send and receive that signal, you'll get the good signal for active cavitation mapping. Or passive cavitation mapping, we rely on the bubble collapse and rebound to send that out. And so the passive cavitation mapping occurs a lot later in the cycle. It's also interesting that they're seeing a lot more bubbles in the passive cavitation mapping, probably related to that time difference between the active and passive mapping as they did for their project. So that's just a brief summary of some of the ways we monitor cavitation in shockwave lithotripsy, how it relates to efficacy and tissue injury. Now I'm going to shift gears a little bit and talk about deep vein thrombosis. So deep vein thrombosis, DVT, also known as venous thromboembolism or venous blood clots, affects about 2% of the population. Here's just a nice diagram showing you've got a vein in the leg, normal blood flow, the platelets and the blood just flows through these valves. And when you have deep vein thrombosis, you have these clots that form. Well, as these clots form, there's risk of that breaking off and to form emboli, which if they travel to lungs and other things, it can become very dangerous or deadly. There are about 100 to 300,000 deaths per year from DVT in the US at a cost of about $15,000 per episode. Now, DVT is usually diagnosed by duplex ultrasound. MRI or venography can also be used. Here's just a lovely image of DVT showing with duplex ultrasound showing the femoral artery, the femoral vein, and we're getting no flow in the femoral vein that's occluded. The deep femoral vein is still open. DVT can be treated with thrombolytics, filters, catheter interventions, or sonothrombolysis. So the big thrombolytic that's used is recombinant tissue type plasminogen activator, or RTPA, or just TPA. Filters try to prevent these large emboli from coming off of the clot. Catheter interventions include removing the clot, aspirators, stents. The ECOS unit works to use ultrasound, but we're going to focus on sonothrombolysis, which uses the thermal and or mechanical effects of ultrasound with and without echo contrast agents to lyse clots. Now, research has shown the thermal mechanism isn't very big in sonothrombolysis. Originally, it was thought to play a role, but evidence has shown not much of a temperature increase. Mechanical effects we see on the left, we see this bubble oscillating and causing pitting of the surface of the clot. And then on the right, we see the stable cavitation where here's the clot boundary. And basically, as this bubble oscillates, it's forming a tunnel through this fibrous clot. And that allows for then RTPA and other thrombolytics to help dissolve the clot. So PCD has been used to evaluate lytic rate for stable cavitation of DEFINITY microbubbles with freely circulating RTPA. So this is out of the Holland lab, paper led by Ken Bader, showing that as our concentration of RTPA increases, we get more lytic rate. Basically, it's showing when we have 0, we don't get very much lytic rate just from the stable cavitation alone. But as soon as we add the RTPA, we do get more and more clot dissolution, not necessarily related to the quantity. And this is shown to be mainly stable cavitation. He's looking at the ultra harmonics. There's a little bit of broadband emission that, of course, can also help break up the clot. But the stable cavitation plays a big role. And basically, that's all you need to form these tunnels and allow the RTPA in to help dissolve the clot. Others have used nanodroplets, so these phase change contrast agents, a combination of stable and inertial cavitation, and this was by an intravascular transducer showing lysis in a retracted clot. This was out of Paul Dayton's group. Basically, retracted clots are those that are very old and fibrous, very hard to break up, and so they showed that at the 0.9 megapascals, they get both stable cavitation and inertial cavitation. And if you look at just the percent mass decrease in the retracted clot, we see a lot more clot breakup with the nanodroplets plus TPA. So the thrombolytic plus ultrasound is better than the microbubble option with TPA and ultrasound, or better than the nanodroplet and ultrasound alone. So this is a fairly new paper showing some very promising results for nanodroplets. Other groups have used the Doppler shift from the superharmonics to characterize microbubble translation. So if we look at this Doppler plot on the left, we see as our pressure increases, we get more and more of a negative frequency shift. This is for the 10th harmonic because you need the frequency high enough to be able to detect those Doppler shifts. But basically what it's showing is as we increase pressure, we're getting faster and faster microbubble translation, which we can back out from this Doppler shift. If we look at a time frequency shift, we see just a little bit of broadening at the 147 kilopascals. As we go up to the 217 or 294, you're seeing this larger and larger Doppler shift that's happening as the microbubbles are basically pushed faster. When we get up even higher to 366 kilopascals, we don't quite see the same trend, but if we look just in those first few milliseconds, we do see a larger shift, which then goes away that they expect is due to inertial cavitation breaking up microbubbles in the focus. The motion of this gets very complicated. You start to get streaming and other circulation that happens. That's why we only see the negative shift. But I thought this was a pretty cool paper that's using Doppler to look at how the bubbles are moving. So others are using combined photoacoustics and B-mode imaging for microbubble-mediated sonothrombolysis because it allows for better monitoring. In sonothrombolysis, when you get those microbubbles in, it can basically occlude your field of view, and so we don't know how well the clot's broken up. This group claims that if we use photoacoustics, you do see that increase of signal between before and after sonothrombolysis that they're expected is related to these microbubbles forming these pores or channels through there, softening the clot and allowing more of a photoacoustic signal for better monitoring of how well the clot's broken up. I've worked with a group at Penn State here to look at Doppler ultrasound with their phase change nanodroplets to evaluate clot boundaries and monitor dissolution. Basically, there's not a lot of work understanding how the lytics break up the clots, how the clots form, how they break up, what are the kinetics. And so what we did is we looked at both with and without these nanopeptisomes in a just in vitro flow loop and see that, well, when we inject thromboplastin, we do get a clot that forms. It backs up and we don't see any blood flow happening. When we add the nanopeptisomes, we do get this twinkling artifact. So going back to the kidney stone, when the nanodroplets change phase, we get this rapidly changing Doppler color that we can detect. And that kind of helps illuminate the clot border that forms. Now, what we didn't expect is as part of this, we inject the thromboplastin with the nanoparticles already present. It basically prevented the clot from fully forming. So as we look at a time chart over here, we see, well, there's a little bit of clot that we can see a boundary of at 7 minutes, but at 14 minutes, basically the clot's been dissolved by the activation of those nanodroplets and competitive fibrin binding. So others are working, and still ongoing work is integrating therapy and monitoring systems to improve cavitation monitoring and just to have integrated systems. So Vignon's showing that you can use just a linear array to be able to do echo pulses interleaved with sonothrombolysis and be able to track the cavitation activity. Out of Dr. Hinnanen's group, we're seeing just different array designs. So basically this hemispherical idea, can you use that to, or you can use that to get higher frame rates, better spatial resolution. Just the question is, where do we put the therapy transducers versus the receiving transducers to be able to get the best signal? So long story short, kidney stones and DVT therapies can be monitored with passive cavitation detection or imaging, active cavitation mapping like B-mode and or Doppler ultrasound. So kidney stones may have these pre-existing surface crevice bubbles that are leveraged in a lot of therapies. And then the therapies use inertial cavitation and elastic wave to break the stones. We still need to be able to monitor between breaking the stone and then causing unwanted tissue damage. Sonothrombolysis for DVT shows that clots can be lysed through stable and or inertial cavitation using circulating microbubbles or nanodroplets. Histotripsy is also under investigation to create those bubbles and break up the clot. And thrombolytics are very important to help enhance that clot dissolution as the sonothrombolysis works. So my couple top identified challenges that remain, echoing last week's workshop, standardization of PCD, PCI collection and processing, I think is still very important for all these therapies. Big one of kidney stones, but also for DVT is, can we elucidate what's therapeutic cavitation to actually break up the clot or kidney stone versus causing that tissue injury? Is there something from the signal we can get out that tells us, ooh, this is basically bad, we're injuring the tissue, versus therapeutic? And then finally, getting consistent clinical adoption. In shockwave lithotripsy, there's been a lot of research showing if we slow the shockwave rate, we can enhance fracture efficiency and reduce tissue injury. But the challenge is getting that actually into the clinic where they're getting that buy-in. Yes, it'll take longer for the therapy, but it will be more successful. And I think similar challenges will be faced by DVT as we get sonothrombolysis more into the clinic. So this finishes up my talk. I'd like to thank you for your attention, and I look forward to the panel and answering any of your questions.
Great. Thank you very much, Julianna, for an excellent review talk. While we wait for some audience questions, one I had for you was, one of the challenges you mentioned is in distinguishing between cavitation that's therapeutic and cavitation that causes injury. Can you talk a little bit more about what's known about these regimes and what additional information do you think is needed for their evaluation?
Well, I think it's not that clear of how we can distinguish between the two different types of cavitation. I think there's a lot of work that can be done there and should be done there. Can we tell if we're, for both of my two cases, DVT and kidney stones, we're really wanting cavitation in the fluid-filled space, not cavitation in the tissue. And so definitely different tissue paths, different environments surrounding those bubbles that should be able to be backed out with PCD, PCI. Doppler imaging is pretty interesting that it's being used in both areas. Again, looking at that motion, that flow of, and how it relates to the bubble. So I still think it's a big challenge that's remaining, but it would be useful for pretty much all areas where we use cavitation to purposely cause injury or not.
Great, thank you. So we have a question from the participants that reads, in our extensive experience with sonothrombolysis, both types of cavitation have enhanced RTPA lysis, not the other way around as you presented. Can you comment on this detail in your presentation, please?
Yeah, sorry if that came across the wrong way. Definitely both types of cavitation enhance RTPA lysis. There's different mechanisms that are proposed to do that. The stable cavitation can kind of form those tunnels that allow the bubbles in. The inertial cavitation can kind of have the same effect of breaking up different parts of the clot, allowing the RTPA in. Only having 15 minutes to talk about two areas, you have to kind of pick and choose what you can show. So definitely thanks for that correction that it can be both types of cavitation.
Great, thank you very much. We're going to move on now, but please do stick with us and come back for our panel discussion in a little bit later. And I'll turn it back over to Kevin now.
Thanks, Mike. And it's my pleasure to introduce our last speaker for this kind of first part of our session today. And that is Professor Costas Arvanitas, who received his PhD from University College London before embarking on postdoctoral fellowships at Harvard and at University of Oxford. So you can also ask him if you want, which of those schools is actually better. But while he was there, he made some important contributions to the field of cavitation-mediated drug delivery. And subsequent to that, he founded the Ultrasound Biophysics and Bioengineering Laboratory at Georgia Tech, which has been as wide-ranging in its contributions, in my opinion, as it has been prolific. He's received a prestigious NIH Merit Award, amongst others, as he's been advancing our field. In particular, he's been a leading voice on developing cavitation-based controllers, and that's what we've asked him to discuss today.
Hello, everybody. I would like to thank Kevin and Mike for the opportunity to present the recent developments on feedback control methods on microbubble-based ultrasound therapy. So let me start this brief tutorial by underscoring the need for feedback control methods on microbubble-based ultrasound therapy. So why do we need feedback control methods? First and foremost, it is hard to estimate the focal pressure, especially behind the bones. Also, unless the treatment is based on mechanical ablation, we must limit inertial cavitation, and especially in sensitive organs like brain. Also, the relatively fast microbubble clearance and the limits on the number of microbubbles that can be administered to patients imposed by the FDA impose significant time constraints for tuning and optimizing the sonications. So we also need to be able to account for microbubble type and also batch-to-batch variation, which can be significant. We need to account for tissue heterogeneity that might lead to different microbubble oscillation damping mechanisms that may also result to suboptimal effects, account for focused ultrasound system instabilities, minimize human error and excessive treatment durations, and ideally prescribe specific mechanical dose and ensure high reproducibility. So I would like to close this brief introduction by providing a serendipitous observation during blood-brain barrier opening experiments that demonstrated that it is possible to attain safe and uniform blood-brain barrier opening over a large brain region. And here there has been employed a 3x3 sonication grid. So the goal of the control-based method is somehow clear, and that is to attain these responses in every target, in every patient, at every time. So let me, with the goal of the control somehow defined, we can now turn our attention to the different control laws. So before we consider more realistic implementation, it's best to define the ideal controller. And the ideal controller should directly control the microbubble radius as a function of time. In fact, this has already been done extremely well. Here I provide the work by Dadok and Zeri, as well as Carroll et al. And as you can see, they have already demonstrated remarkable levels of control of microbubble dynamics upon the activation of the controller. So in this work, formal control theory based on Rayleigh-Plesset type of equation has been used to define the objective function and control the microbubble dynamics at an arbitrary trajectory. Here you see some examples that I took from these papers, and you can see almost perfect overlap between desired microbubble oscillations and the one that has been prescribed. However, the most important limitation of this theoretical solution is that the controller requires as input the bubble radius as a function of time, which is particularly hard to obtain under realistic conditions. As such, current implementations are based on direct estimates of microbubble dynamics based on microbubble acoustic emissions. And although you have seen in this workshop that it's absolutely feasible to record different spectral components related to microbubble emissions, this is not a trivial problem. And this is because there are challenges in attaining reproducible emissions and recordings. See last session for more information about that. Microbubble concentration and properties might affect the emitted signal. Microbubble kinetics, as I alluded to, can lead to time-varying signal. And also the presence of off-target activity may render the recorded emissions unfit for tuning the exposure. So in the next few slides, I will present the main components and workflow of controller-based microbubble acoustic emissions and how this can be used to mitigate these challenges. So cavitation controllers based on microbubble acoustic emissions use the spectral content of the microbubble emissions used via a passive cavitation detection as a state observer to infer the microbubble dynamics. And then they enforce a control law based on the value of the state observer to change the applied acoustic energy to obtain a desired level of microbubble activity and by extension of bioeffects. So they can be divided in two different broad categories. They're open and closed methods. And open loop controllers have independent control laws that can incorporate predetermined constant input size. And the goal overall of open loop controller is often to meet an acoustic emission threshold. On the other hand, closed loop controllers have output-dependent adaptable control laws that adjust input step size according to current and target acoustic emissions. Overall, the goal of closed loop controllers is often to maintain the acoustic emissions at the target level. Note that both methods close the loop, but the closed loop controllers need to maintain a target level. So cavitation-based controllers based on microbubble emissions have been initially implemented using the harmonic emissions, inspired by the work of Nathan McDonald from Brigham and Women's Hospital, as well as research from Elisa Kononfago at Columbia University that showed good correlates between the harmonic emissions and the blood-brain barrier opening. One of these approaches uses the harmonic emissions to titrate the exposure by attaining prescribed harmonic emissions based on cavitation threshold measurements. So using this threshold approach and manually adjusting the exposure to attain harmonic signal above 6 nm per hertz, this approach was able to provide evidence that it is possible to deliberately attain uniform blood-brain barrier opening. And an observation is that the underlying vasculature clearly impacts both emissions and the observations should be taken into consideration. Overall, controllers based on harmonic emissions offer very high sensitivity as the harmonic emissions are the strongest generated by the microbubbles. They allow to track the microbubble kinetics that can be useful both for mapping and closed loop control. However, the emission does not depend only on microbubble dynamics. Harmonic emissions may be generated by the system or sound propagation or linearities. And this imposes significant challenges in comparing the emissions across different labs, different instruments, and sometimes even across different targets. Although this challenge can be mitigated by background recordings, this is an issue that needs to be addressed every time harmonic emissions are used. At the same time, maybe a few months earlier, O'Reilly and Heenan et al. From Toronto University employed ultraharmonic emissions to control the level of blood-brain barrier opening. And the optimal power threshold with this approach is determined by incrementally increasing the power at the short intervals, as you can see here in the X, until an ultraharmonic signal could be detected using a real-time passive cavitation detection system. And this is the point, is the Y here. Then at that point, the pressure is dropped by 50%, and the sonications remain fixed until the treatment is complete. So overall, controllers based on ultraharmonic offer extremely high sensitivity, specificity, as the ultraharmonic emissions depend only on microbubble dynamics. However, this might not be the most sensitive method, as we really need to drop by 50% the power, and therefore it's good to be able not to exceed the threshold that is required. And also, due to this drop in power, the microbubble kinetics cannot be tracked. It's likewise an approach based on subharmonics have been recently proposed by colleagues from Taiwan, where they use the subharmonics, as I mentioned, to control the blood-brain barrier opening. This method is based on calibration, where the threshold level of subharmonic energy spectral density equal to 5.5 decibel is used as a predictor of blood-brain barrier opening. In this controller, as long as this value is met, then the controller stops and the treatment stops, and the investigators have shown really good opening of the blood-brain barrier and with safe conditions. So overall, this controller has very high specificity, again, as the subharmonic emissions depend only on microbubble dynamics. It can be slightly more sensitive than ultraharmonic method, as it uses lower frequencies, but also has limited ability to track the microbubble kinetics, which can be important. So a combination of the above approaches is currently used in the clinics using the Exablade system that uses the same power ramp approach that proposed by O'Reilly, but instead of superharmonic is using the recordings from subharmonic. And it has already been shown here. You can see a metric that the company is using called harmonic dose, which essentially the controller tries to reach a level and then it stops. You can see an overlaid map of the strength of the harmonic dose with respect to target brain region. And this method has already been shown really reproducible and robust responses in the clinical setting, both at different disease states, including cancer and Alzheimer. So, and finally, an open loop control designed by Kamimura et al. From Columbia combines more than one spectral component. In that case, the controller uses both harmonic and ultraharmonic emissions to reach a predetermined threshold. And when this predetermined threshold is reached, the treatment is finished. If broadband emissions are detected before this threshold, then the maximum negative step is employed and the treatment continues at that level. Also, good responses have been observed with this controller in non-human primates, and now it's currently at the clinical setting. So overall, due to the characteristic of open loop controller, safety is ensured and was very robust, and clinical translation has already been performed with those. However, they have a very small rise time, and also because of the small steps employed, they cannot respond to sudden changes in the acoustic emissions during the sonications, and this can be quite important for many reasons. So to address these challenges, closed loop controllers have been put forward. And here you can see an implementation by San et al. From Brigham and Women's Hospital, where the control law uses a proportional feedback that adjusts the pressure increment proportional to the difference between a target output state and a current input state. So this is here now we're adjusting the step size, as well as an integral component where cavitation dose is used for seizing criteria. And you can see very, very narrow responses in terms of acoustic emissions have been attained. Infusion seems to be much better, and very good and reproducible delivery of drugs in healthy and diseased brains have been attained. Likewise, this method using only the proportional part, not the integral part, has been tested using the Exablade system by McDonald et al. And using a custom-built passive cavitation detection. So in this method, in this implementation, the controller tries to reach a predetermined level and tries to maintain that level, as you can see in this plot here. However, because of the microbubble kinetics, the controller operates only for roughly 15 to 20 seconds. And after that point, the controller keeps the highest, the pressure that has been at the last steps and until the treatment is complete. Again, extremely good responses have been observed with this controller in glioma models using carboplatin drugs. We have been recently refining a nonlinear state controller that adjusts the pressure input according to third harmonic emissions level and using how close and how far is from predetermined trajectory that is based on calibration curves from a database that we assembled prior to the experiments. And here you can see the controller is also using a surrogate plus pulse that tracks the microbubble kinetics that indicates the controller when to be activated and deactivated. And also the controller takes a maximum negative step when no broadband emissions have been determined. And we're currently observing that the exposure-dependent blood-brain barrier opening and safety can be attained with this method. Here you see that if all the safety features are not in place, damage might occur. And also infusion is preferred method as it provides sufficient time window for the controller to operate, in this case, more than 40 seconds. So finally, what we were interested in, we employed a closed-loop controller that I mentioned before in the previous slide, using passive acoustic mapping based on the angular spectrum method. Using this method, we are now able to control the microbubble dynamics using a region of interest in the passive acoustic map that also uses specific spectral components in order to reconstruct the acoustic field. And we are able to sustain and maintain stable cavitation in these in vitro experiments. A key finding of this paper was the ability to control the microbubble dynamics in the presence of cavitation activity at multiple regions. As you can see here, that controlling for the cavitation activity beyond the FUS focus, we require much higher pressure, which is consistent with a pressure drop due to the distance of the tube from the focal region, which provides the highest possible pressure. So here's a summary of the pros and cons of the different methods to control the microbubble dynamics, with subharmonic and ultraharmonics offering high specificity, and harmonic method based on a harmonic controllers offering high sensitivity and the ability to track the microbubble kinetics. Here I provide some questions that I think will be quite important to address moving forward and may allow us to develop universal means to quantify and control acoustic cavitation. For example, what calibration methods are needed to attain system-independent quantification of the microbubble acoustic emissions? I hope this workshop will help us to address this question. Another question is, can we directly control the microbubble dynamics? While this might sound quite far out there, I would like to mention a work from Nico de Jong's lab at Erasmus University, where they saw that it is possible to track the microbubble radial strain using acoustic methods. And maybe one day we might be able to do that in the brain. So this might also pave the way to be able to control the forces exerted during stable inertial cavitation, which is what we are really aiming for using all the methods we have employed. So with that, I would like to thank the students that helped work in our lab for the controllers, Scott, Arpit, and Henry, and also NIH and NSF for supporting our research, and you for your attention. Thank you.
Fantastic talk, Costas. Thank you very much. Really thorough overview, which is wonderful. You might be on mute there. So first question that was posed by the audience is, you talked a lot about the brain, but can you talk a little bit about controller design for clinical applications not in the brain, particularly where movement of tissue might be involved?
Right. So when movement involves, I guess the biggest challenge would be to consider whether, to some extent, you might have to use mapping or might be assess the bioeffect involved. So I think when movement is involved, the challenge is like, do you know where cavitation happens, right? So that's, if you are able to know where, cavitation happens at every location, then in principle, these techniques can be applied. But I think the problem here is not the controller. The problem is tracking the cavitation in space in terms of location. So I don't know. That will definitely complicate things, because you really need to have being able to track, the controller that you had in a given case, in a given location, what has happened. It will complicate calibration results, because calibration results to some extent rely on, you assume that the system is stationary. We also record a lot. If you use harmonics, for example, we do record background data. And that kind of brain is quite friendly with this kind of notion, because if you assume that everything is stationary, then the only change will be the bubbles. So you can kind of remove any background signal that you think that was there before the bubbles, and you can account for that. So yeah, I think it will just add another layer of complexity that needs to be addressed. So essentially you hold to control for the specific location, right? So if the location is not fixed, then it's going to become more challenging to control for it.
Excellent, great answer. It sounds like an area ripe for some more work to be done. The next question I wanted to ask you is from again an audience question. They said the harmonic emissions that are regulated in your closed loop controllers, do they use absolute measurements and relative measurements? And also then in the context of that, how important is the equipment and the precision of the calibration?
Yeah, that's a very challenging topic. The question is, you really want to use relative measurements, so you really want to remove any background. However, the question is how you do this removal. And to some extent, any processing that you do the data, you go, for example, you convert them to decibel, which is a nonlinear transformation of the data. Any processing that you do the data, you will end up compressing the dynamic range of the data. And that might make the different and discrete states that you might want to attain much more subtle. So it is important to account for that. And that's what every controller should have, I think, should try to get some measurements of the microbubble dynamics, irrespective of nonlinearities involved. But at the same time, this comes at the challenge that you compress your data with any transformation you make, and this might make things more challenging. We've been quite successful with just recording the data and creating a database and being able to apply a controller that was extremely sensitive and was able to attain different states. And we've found some challenges when we try to convert the data to decibels, because essentially you squeeze the data to a very narrow range. So the controller now has much more harder time to discriminate between different states. It's a very challenging topic, and I think needs to be addressed, depending on what signal you're using as well. So if you use ultraharmonics or subharmonics, this might not be that challenging, for example. But you need to establish different layers of harmonics, of ultraharmonics and subharmonics, that they're kind of unique spectral signatures that don't depend that much on the background. You just kind of you have an electronic noise and that's it. So those spectral components have these desirable characteristics, and I think this is what kind of made people think to go down that path of using these spectral components for controlling. But harmonics are the strongest signal that we have. We know that from imaging. So it provides some desirable characteristics, especially for applications like brain, where attenuation can be an issue. But it comes with caveats.
Great, thanks. And that questioner actually took my bait, and they want a quick follow-up on are US or UK schools better?
So come again, R?
They took my bait. They want to know, are UK schools or US schools better?
Right. I think, everybody has to find the right environment for them to be creative and being supported by the right team, and doesn't really matter where you are. Wonderful
response. I love it. And then last question, and we're a little over time, so if you could try to be brief, but from the audience, they want to know, for the surrogate pulses that you're using to track your microbubble kinetics, they appear to be lengthy in duration, 10 milliseconds or so. Are these pulses potentially contributing to focused ultrasound induced bioeffects? And in some ways, would shorter pulses be better?
Right. So we decided these pulses based on correlations that we have, or based on the harmonic emissions in K-trans values, which is a proxy of permeability, assuming perfusion is constant. And at that level, we didn't see any changes in the K-trans. So you may argue that there are changes, but the MRI is not as sensitive enough, but we did not find any changes. And this is how we decide about the maximum pressure to use in this. We were able to track the harmonics. First of all, you need to be able to track the harmonics. So that's one thing. So the pressure, you need to give you good SNR, so you have confidence about the uptake and the loss out of the microbubbles. So the second is the pulse duration. So in that experiment, this clearly is a proof of concept experiment. And we need to make sure that we kind of like have the same spectral information, the same components with a pulse that we used for the controller. So we just kind of like use 10 millisecond pulses. You might argue that that's too long, could be shorter, could be much more efficient. It's kind of like, it's for us, is always a decision, is like where kind of like science and where kind of like refinement starts. And, having 10 millisecond, 1 microsecond, 3 microsecond, I think it's kind of like goes down to what is best and why. But for proof of concept study, I think this clearly demonstrates that you can, having this surrogate pulse can be quite important, because it's quite important to realize that microbubbles have different kinetics. Microbubble properties produce different mechanical effects. Microbubbles have if we use microbubbles, you really need to take them into account, not just like blindly use the harmonic level. So being able to track the kinetics of the microbubble, I think it gives you the ability to at least use the controller at different microbubble types that maybe for a different country that you mentioned before, Europe or US. Europe and US, they have different bubbles that are approved. So this might allow you to be able to, for example, use the same principles in the controller, but apply them at with different microbubbles that, for example, Optison has much faster kinetics as compared to Definity, right? So that you cannot just say, I'm going to go for 10 seconds. You have to use it as long as possible. That's the goal.
Okay. Fantastic. Well, thank you very much. I appreciate the insightful responses, and we look forward to you joining us on the panel. And with that being the conclusion of our speakers for today, I'm going to pass it back to Fred, who's going to give us a little bit more timing for the remainder of our session today.
Well, thank you very much. Thanks to the speakers for these fantastic presentations. We will take a 10 minutes break before resuming for the panel discussion, where the speakers will be joined by Dr. Catherine Ferrara from the University of Stanford and Dr. Juan Vidal-Jové from the Institute Club for Interventional Oncology from Barcelona. So see you in 10 minutes. Thank you. To the second part of our session, we will now have a panel discussion with the speakers and 2 other moderators. I just want to remind you that the Q&A is active, and we really encourage you to post questions, comments. If we don't have time to answer them directly during the sessions, we will record everything, capture everything, and we'll post some feedbacks on our website. And with that, I think Kevin will introduce the first moderator, panelist.
Hi. All right, welcome back. And we will now begin the panel session with the aims of exploring the critical issues in cavitation imaging that were raised during this morning's presentations and discussing key steps that can be taken as a community as a whole towards resolving these issues. And I'd like to begin now by introducing our featured panelists, Dr. Catherine Ferrara and Dr. Juan Vidal-Jové, who we are exceptionally grateful for having with us today. Kevin?
Thanks, Mike. I appreciate that. So yeah, it's my pleasure to introduce Professor Ferrara for this session. She received her PhD from the University of California, Davis, has had stops at University of Virginia, back at her alma mater at UC Davis, where she was also the founding chair for the Department of Biomedical Engineering. And she's currently a professor of radiology and division chief for molecular imaging at Stanford University. She's a member of the National Academy of Engineering, has numerous fellowships in professional societies, including the AIUM, and has received many, many awards for her scientific contributions. Now, she brings to this panel not just a deep expertise in ultrasound imaging, in cavitation and drug delivery, but also a great deal of expertise in other fields that hopefully can help potentially inform our perspectives as we move forward. And a great example of this is a recent 2020 Nature publication on novel positron emission tomography imaging. Professor Ferrara, thank you for joining us, and I'd like to offer the floor to you now to just provide some initial reflections on what you've heard today. Thank you.
Thanks so much. Yeah, I want to say it's been a really remarkable morning. I think that The presentations that I heard were phenomenally technologically empowering, and were really a great overview of the field of mapping and the technology. I think that what I heard was particularly broad in the area of blood-brain barrier opening and passive acoustic mapping, and really struck me the need for further availability of helmet arrays. It was clear that several of the groups, particularly in Toronto and Michigan, have been able to create some really unique technologies, but they're not widely available in the community. Otherwise, also many very sophisticated strategies for being able to monitor cavitation were presented, and the need to standardize or to do cross comparisons seems like a really important goal. And we saw also applications outside of the brain, including thrombus dissolution. But I guess from our own work, just to give a bit of a contrast of the kinds of things that we've been doing in addition, we also have looked at strategies such as using bubbles and cavitation to transfect tumors to produce immune cytokines, chemokines that are anti-tumor, and found that there really is an opportunity to change the tumor microenvironment by using microbubbles and ultrasound and plasmids. And just another application, but another application that brings a different set of tools. So for this application outside the brain, it's feasible to have just standard two-dimensional arrays, and we've really sought to create 1,000-channel capabilities with 1,000-element arrays that encompass the range of frequencies from, say, 1 megahertz to 4 megahertz, and to be able to use technology like this to map cavitation activity, either with just nonlinear microbubble strategies or with the beautiful passive acoustic mapping ideas that others here presented. So I do think there are other applications. Another application that we've been pursuing in combination with the Gazette lab at Cedars-Sinai is fracture healing. And so there we've looked at the ability to use microbubbles and, again, plasmid to cause fractures to heal. So I do think there's a broad space and a broad set of technologies that can be applied to this problem, but really a beautiful set of presentations to cover some of the methodologies that can be employed.
Wonderful. Thank you very much for that introduction. And I'm going to turn over to Mike to hear from our other panelists to open us up.
Thank you, Kevin. Dr. Joan Vidal-Jové is a surgical oncologist and is director of the Comprehensive Tumor Center Barcelona within the American Institute for Interventional Oncology. Dr. Vidal-Jové is a world-leading clinical authority on therapeutic ultrasound, having treated hundreds of patients for indications including liver and pancreatic cancer. And we're very excited to hear his perspective on cavitation imaging and its clinical implementation. So I'd like to invite him now to give us some introductory remarks. Thank you.
Well, first of all, thank you for inviting me to be here. So for me, it's been challenging following most of the presentations today, this morning. But I want to congratulate all of them because I think it makes me feel that we are in good hands to solve our real clinical problems that we have when we're trying to treat a tumor in a patient. And what I want to emphasize is that we have at this moment 3 clear needs, and probably, and I want to introduce 3 challenges. So the clear needs that we have in real-time monitoring of our cavitation ablations is, first of all, identify the lesion, identify the tumor, and identify the normal tissue. So identify the margins that we want to preserve when we treat the tumor. So treating the tumor and adding some margins, this is a key issue there, and we need to clearly identify that. We also need to identify structures, and because our cavitation affects the tissue, but should not affect other structures like vessels, like ducts. We need to preserve those. And we also need to identify materials, because when we do an ablation, sometimes we need to identify like a biliary stent, for instance. So the most challenging situation will be to treat a pancreatic tumor that has inside a biliary stent in the middle. And we need to treat the tumor, have some margin, and preserve this biliary stent. And then dealing with difficult situations. So what happens when we have more bubbles in the field? So we also, cavitation with bubble clouds, it's one thing, but then we may have some other bubbles in the field for diagnostic, for instance, if we do a contrast enhanced ultrasound, or for treatment. We may use bubbles to enhance the cavitation. And what happens when we deal with these two types of bubbles? We have to deal also with sonication interferences and artifacts that happen at the real time when we're doing the ablation. And what happens also with movements, with respiratory gating, when the field is not stable, when we're dealing with the breathing of the patient and we have to hold still sometimes, dealing with our anesthesiologist to have a very subtle, a very shallow movement of the respiratory breath to keep the target still. So I hope that these discussions that we're going to start now can bring some light here and help us in the future treatments that we're going to perform in coming weeks.
Excellent. Thank you very much. And I'd like to use your presentation as sort of a jumping point to bring in the rest of the panel as well. And as we talk about some of the complexities that you're facing in the clinic, one of the questions that's come up today repeatedly has been about kind of generating some common standards and some common reference radiological metrics for some of the things you were just identifying. You would like to identify structures, materials, and so forth. Are there some thoughts on how we might develop such a set of radiological metrics that could be used for a variety of platforms and procedures? Yes, Constantine. Unmute, please.
I have a question that I'd like to ask Joan and Kathy and others for discussion, which is, we talk a lot about the monitoring of the cavitation today, but to a clinician in particular, there's also the question of how we present that cavitation monitoring in a way that is useful, particularly when you're trying to navigate around other structures, and particularly when you do it in abdominal organs where respiration will lead to significant organ motion. So what do you think cavitation monitoring, John, from your vast experience of it, should be integrating with in terms of preoperative and intraoperative imaging to be useful? What is available to you as a treating clinician a priori is probably MR, CT, and in some cases PET. What we get during the treatment is with a patient in a different position very often than the one in which they would have been imaged preoperatively. What do we need to superimpose this cavitation information onto to be really useful to the treating clinician?
Well, that depends on the organ. So if we're dealing with liver, we need both ultrasound and MRI, because those are the most selective, and we need to make all those together. In order to planify or to make the strategy previous to the treatment, we use both, but we use more the MRI in order to make the strategy of what we're going to do, where, when, and what there's the relationship with vessels, with with the hepatic veins, with ducts and everything. And this is for a strategy. Probably MRI is the best. If we could have some fusion between MRI and ultrasound during the treatment, MRI would be the only one thing that we would need. But the problem now is that on real time, we have to use ultrasound. And ultrasound today, it's very useful. If we could use ultrasound, contrast-enhanced ultrasound. And that's why I mentioned this, what happens when we have more bubbles on the field. So if we could have contrast-enhanced ultrasound at the same time that we're using a histotripsy ablation, that would be wonderful. But at this moment, we don't know exactly what's going to happen if we have the bubble cloud there with the other bubbles. But answering your question, for liver, ultrasound and MRI. For pancreas, it would be different. Probably would be better CT scan and also ultrasound. And probably for brain, I would say also MRI and ultrasound.
Kathy, is there anything you might want to add to that particularly from your expertise in drug delivery, in terms of how do we fuse cavitation information with other imaging modalities to make it really preclinically and clinically useful?
Yeah, I think that that move to 3D ultrasound, and we're still really thinking about how best to present. We do have two-dimensional ultrasound arrays that we can use to either acquire a passive acoustic map or a map of bubble activity using more traditional techniques. But it's a great question as to how to present, whether presenting orthogonal planes. We've created displays, and as some of the commercial instruments have as well, with a set of parallel images as well that allows you to visualize the activity in the 3D space. But I think we're still in early days of clinical acceptance of those techniques and utility of those techniques. And I do think it's important for ultrasound, even beyond these applications, for ultrasound to have a bigger role as 3D ultrasound becomes more available, have a bigger role, and even just monitoring tumor therapy, for example, being able, we typically don't see 3D ultrasound being used to monitor changes in tumor volume over time, for example. So it just gives you a sense that we've really got a ways to go to realize the acceptance of 3D ultrasound and its ability to monitor activity or changes over time. And I agree, fusing that with other modalities is certainly an interesting application, and something that has been pursued. My clinicians tell me here, at least, there's less activity in that area than there used to be, surprisingly, but they do find in some circumstances certainly it's useful, and particularly with combinations of MR and ultrasound, I think could definitely be very important.
So Megan and John, I was wondering if you could comment a bit more about the 3D imaging problem. Kind of what's the state of the art right now in terms of data capacity and data flow? And do we need a time machine first, or are we kind of around the corner?
A little bit of both. On the histotripsy side, if you're trying to collect those 500 microsecond duration signals to map the whole field, you have to be able to transfer that back to the host computer fast enough to do real-time imaging. And we're kind of limited by Ethernet bandwidth right now. So we can hit gigabit speeds or 10 gigabit speeds, but if you're trying to capture that long a signal on that many channels, even if you're at the maximum rate of Ethernet, you can go 30 hertz for the 360 channels. But one of the things, that you could do, at least, based on the signals that I kind of presented before, is, our array is controlled by 45 separate microprocessors. So we can put a lot of that signal processing on those microprocessors themselves. And so if you can identify, say, just the peaks in those signals, then all you have to do is transfer back that time, and then you can do simple trilateration or beam forming, and then just look at single points with very limited data transfer required. It does depend on you having that singular kind of spike in the signal, but if you do, then it can be
quite quick.
So I think for the brain barrier or some of the longer pulse treatments, the problem's a little bit more challenging. So typically to date, people have dealt with it by either temporally undersampling and taking just a portion of the signal, or if you're doing multiple exposures interleaved, sampling one subspot and then using that to kind of represent the area. So there's a couple challenges. One is just transfer rates, and one way to maybe get around that is going to something like FPGAs, where there could be hardware implementation of some of the beamforming, and they don't actually need to transfer all of the data to host. But even then, once you have it and you want to beamform it, right now we're really working with relatively small volumes. They're like 21 by 21 by 21 voxels, or maybe 41 by 41 by 41. So in the scale of the brain, that's actually a pretty small volume. And ideally, we would see everything, including the extracranial space. But to generate that, we need a lot of processing power to, even with fast beamforming methods, it becomes a challenge. And then you have these huge data sets you need to actually figure out how to display in a nice, usable way for the user. So there's a number of different challenges. I do think on the processing side, AI will probably give a big boost. Typically, my view of AI is that it can be a useful tool. I think we still need to have robust algorithms, underlying all of that, but it may be a way to accelerate it. Once we've tackled the other hardware challenges.
So I might shift the discussion a little bit here. We've heard both in the talks and in the opening of our panel here quite a bit about some of the challenges we have ahead of us. And I think before the end of this panel, we'll return to those. But I'm wondering if we might spend a little bit of time talking about, is there any consensus on things that are settled at this point in the field, right? Things that we can kind of say, this is good, everybody should just do this, let's agree on that. And so that we can move on and focus on other things. And this could range from hardware to beamforming algorithms, et cetera. And it's open to any of our folks here.
Seems like maybe nothing is settled.
The silence speaks volumes.
I think both for the work in the brain and the work in drug delivery and in separate applications, I think there is broad consensus that we need to be able to monitor and differentiate between non-inertial and inertial cavitation, either for safety and efficacy. It seems to me that the ability of any system to qualify, to characterize the type of cavitation activity you're getting seems to be the consensus amongst research groups and has been for quite some time. I think what is perhaps less of a consensus and perhaps warrants discussion, I really like Jonathan's comment, don't put all your eggs into the fully calibrated basket or something along those lines. Because I think that's a very, very interesting question of whether we can actually get away with either qualitative or relative measurements or measurements which are absolutes but a different kind of absolutes, which I think is what you were suggesting, or whether we really do need, because of the differences in setup that Kathy, for example, outlined between research groups. Some research groups have fantastic kit and not everyone necessarily has access to the same kit. So how do we compare between the groups that have the fancy kit and the groups that don't? Is a very interesting question to ask. So whether there's a need for imaging calibration or whether there's another way to do it that is perhaps more widely accessible is, I think, a really worthy point of debate.
I do like that question. I want to come back to that, but I actually want to go to the first part of your response, Constantine, to get your take and others' takes on we need to differentiate the different types of cavitation. Do we have consensus on how to do that? How to differentiate whether we call it inertial and non-inertial, inertial and stable?
If you only generate inertial, then the question is solved. Sorry, it's the histotripsy in me.
I'm sorry.
I mean, I think every presentation today spoke in terms of narrowband versus broadband emissions in some shape or form. So this is one of those where if someone disagrees with that way of segregating the behaviors, now would be the time to say it. I see Costas as a yellow hand up.
Yeah, I think the outstanding question I think that might be we need to address is how we're going to kind of like think about considering grouping all the different kind of like flavors and research that is happening. And I think there are kind of like two different ways that we can go about. One is we can either follow the application paradigm that is provided by the clinical setting and clinical need and start thinking about there are applications in the brain, there are applications in the liver, there are applications in different organs, and there are also different diseases that essentially create an environment that cavitation takes place and effectively influence cavitation to a great extent. Therefore, we have to focus when we start to reach the consensus for different kind of like, disease and application models. I think the other way to see that is to think about what is the effector, and the effector is the cavitation, right? And I think maybe we might want to think in terms of like separating or grouping our thinking in a way like, what is the cavitation nuclei that we have? Are we exploring in the endogenous cavitation, right, as it is happening in histotripsy? Are we using microbubbles where really microbubbles take out all the stochasticity that we know from our textbooks, right? So we have really robust and reproducible signals when it comes to microbubble. And if you have reproducible microbubble manufacturing, things can become quite robust in many ways. Or you can go to nanodroplets or other kind of like ways, nanocaps or other ways that you can potentially initiate cavitation. So I think if we're kind of start thinking in terms of like what is the most like, a way to group the different flavors, I think it might be much easier to reach the consensus. And I think it's definitely, my opinion is we should steer away from coming up with like a unified theoretical framework on how to relate all those things, because I think the complexity is quite high.
Fantastic, thanks. Other thoughts or comments on that topic before we move on?
I would just echo that. I think that, there's so many things that are application specific or specific to the type of cavitation of the nuclei. To agree with Jonathan in his push for intrinsic cavitation, when you're doing histotripsy with intrinsic cavitation, you can relate the destructive effect of that bubble to the tissue destruction, right? So there's a direct correlate. But when we're doing drug delivery, we are looking at an intravascular cavitation signal and trying to tie that to what eventually ends up in the extravascular space. And so that has a number of other confounding factors, not to oversimplify histotripsy, but there's many things that, depending on the vessel diameter, the vessel type, that might not be a straightforward correlation. So I think we do need to think in terms of, is it bubble assisted? Is it intravascular? Is it endogenous cavitation? Is it extravascular? And maybe group along application areas. And then again, specifically in tissues, where the tissue type is going to impact that bio effect that results from the same kind of cavitation level.
Fantastic. I appreciate those responses. I'll get to you in just a sec, Constantine. I think that's something for us to think about at this workshop, right? We have several sessions left after this, and our final session is an overall wrap up, and maybe we need to think about some subgroups within this where we can look at those different particular areas. Constantine, you wanted to add something else?
Just a brief point, which is Megan's last 3 or 4 sentences really rejoin why I asked the question I asked of Joan and Kathy, which is, it's not good enough probably to be mapping cavitation. You want to know whether you're mapping cavitation in blood vessels or in hypoxic tissue regions or in brain. So at some point, we're going to have to think about where the geography of that cavitation map lies relative to crucial tissue structures for that application. And I think that's something perhaps worth thinking about in terms of can we apply certain unifying truths, even though they're not universal truths, to different problems according to where we are in the biology.
Excellent. Yeah. Thank you. Mike, did you want to move on to the next question? We also have a couple in the panel Q&A here.
Yes, we do. So I'll read a comment that hopefully will stir up some feelings. The only definitive measure is that broadband represents bubble collapse. Harmonic signals are only meaningful if you can be sure there is no broadband. Unless there are sensors with high sensitivity and virtually no noise, you may never know for certain that harmonics are free from an underlying broadband. Any thoughts on that?
I have one. So I agree with that. And I just like to say, I think it's made way harder when you're trying to record these through the human skull, because you might be attenuating broadband emissions. And so unknowingly be missing inertial cavitation. So I agree. I think the best we can do is make sure we have highly sensitive receivers, and that we do calibration work. We look at how they respond after attenuation through an aberrator if they're being used for transcranial applications. And we can sort of group into, I guess, suspected stable and then inertial regimes, but it does become very difficult to confidently say in vivo or in situ whether or not you are truly getting only a stable signature.
I disagree. Having no idea who's asked the question, I'm probably going to get myself in a world of trouble, but I disagree with that statement slightly. I think whilst we use blanket techniques to filter harmonic versus broadband signal, everything that has been said is correct. There's a strong possibility that one can never be sure you've just got harmonic or subharmonic signal in the absence of broadband. But I think there are more advanced techniques. I'm thinking here of things like sum of harmonics and Fourier series representations that ensure that you are not able to capture harmonic signal whilst mistaking a broadband underbed for precisely what it is, which is a broadband underbed. And yes, you can never be absolutely certain that there isn't a single bubble inertially cavitating, but there also has to be a judgment call in terms of what meaningful levels of cavitation for that particular application are. So arguably, if you're receiving the emissions from the harmonics or the subharmonics to a certain level, one should not be holding the relevant broadband emissions level to a different standard. You are at that point making a decision of what level of acoustic emissions is significant in your application. So if you're 3 logs down, perhaps it doesn't matter.
Yeah, I'd like to build off of that actually and ask Joan and Kathy to comment on that. Joan, obviously from a clinical perspective, and Kathy, you've done a lot of imaging work with bubbles where there might be some inertial cavitation. So, can we ignore low levels of inertial cavitation and say, there's a little bit of it, that's okay, even if we miss it? Kathy or Joan, if you guys have a comment on that, is that, kind of building off of what Constantine said there.
Yeah, do you want me to go first? I think particularly the brain is certainly the most sensitive and concerning area, and the place in which it would be most important to accurately map the cavitation field. And there, I don't think you could give a blanket statement that is not important to know. Outside of the brain, then we often are looking for or we can tolerate, I think, a broadband signal if we're trying to do something like some sort of tissue transfection. The presence of a broadband signal can be reasonable, and some level of tissue debulking that happens in a cancer scenario outside the brain, particularly, I think is certainly reasonable. But having the ability, and I think our sensitivity, our ability, is we have more tools outside the brain, I think, different transducers, different geometries, different abilities to do beamforming. So I think our ability to sense is probably better, and the applications in which some broadband activity are desirable even exist. So.
Thanks. Yeah, and do you have any thoughts on, when we're doing therapeutic applications on kind of having low levels of potential injury, and again, recognizing that it certainly does matter what the biology is and where you're at. But
yeah, it does, because sometimes we're dealing with different types of tissues, and for instance, we're treating patients that are heavily pretreated with chemotherapy, and those livers have different type of tissue structure, and are more. They can be destructed easily, so that having different intensities there matters, and also having different intensities to protect the dogs, to protect the vessels. So it doesn't have an easy answer that, but yes, we need different sensitivities for that.
Thanks. Anybody else want to chime in real quick on that, or if not, I'd like to move back to a comment that Konstantin made earlier that I kind of pushed off, which was, where we don't have some consensus might be in the realm of calibration. We certainly heard some of that in our last session. We've heard some of that today. Whether we need absolute calibration versus qualitative or relative information. And we do have a question from the audience too that talked about, how do we take these things into account when different groups are also using different algorithms? So wondering if we can get some thoughts on, how do we get some standardization as we have different algorithms used by different groups, and how much standardization do we think we want to try to achieve?
So from the histotripsy, again, standpoint, the reason I said calibration, don't put all your eggs in that basket, the timing of that bubble collapse and nucleation signal doesn't depend on the calibration of the system that's used to measure it. And it does contain information about the energetics. So if you can make that measurement, you don't have to have really any calibration to go along with it. You can think, just going to the simple model of the Rayleigh bubble, that you can get the energetics of the cavitation event just from the timing of it. Doesn't work out quite so well in viscoelastic media, but there's approximations that you can do to get the energy of that event that doesn't depend at all on the calibration of the system used to measure it. So.
And I think even calibration we have to consider has to be application specific. So echoing what Kathy and Joan said, that it really depends. If you're in the brain, you can't handle as many off-target cavitation events as you could in the kidney, in a blood vessel. So while we try to have some good standards, and I think it's good to have standards, the sensitivity is going to need to be a lot greater for detecting broadband cavitation in the brain than perhaps in the kidney. So kind of going back to what I had included in my talk is, can we determine if we have a flow case? So since I was in the kidney and blood vessel, basically good cavitation versus bad cavitation, those off-target effects, because if we think about what we'll probably give to a clinician someday, they're probably going to want basically red, green, like, is this good, is this bad, is probably the easiest solution to give to a clinician. They'd want the feedback of whether this is good or bad, and that's where the sensitivity, the calibration has to depend on where we're looking at it.
I think it might also, calibration is calibration. I refer to the receiving elements in the detection line of the system and of the subunit. I think could be, I'm not sure to what extent we can start, entertaining the possibility of having absolute terms in terms of like this is the force exerted by the microbubbles. But I think it would be quite useful and important to be able to say, for example, when different spectral components, the onset of different spectral components, for example, one product of one company or one lab says that for my experiments, ultraharmonics appear always with broadband emissions. Another lab might say subharmonics appear after ultraharmonics. So there lies the possibility of doing the same experiment across different systems and different labs and still entering in discussions about who has the most sensitive system and which data are the most reliable. So in that sense, if we can account for geometrical and other factors, it would be quite useful to know, okay, that system produces X volts per Pascal versus that system. Therefore, there lies the possibility that maybe these experiments miss something, or this company or the product of this company miss something on their way to translate some basic research and discoveries to the clinic.
Yeah, thanks. I appreciate that. And I mean, that really hits in, one of the comments that's in the Q&A is from somebody that says, in their experience, they always get stable and inertial cavitation together. So I think that feeds in perfectly with your response there, Costas. Any other comments before we shift to a new question? Sorry.
No, I was going to move ahead with our next sort of line of questioning, which is about the challenges of implementation. And I was hoping to start this kind of bringing back in some of the discussion from earlier about perhaps implementing 3D imaging and managing motion. And I was hoping to hear initially from Julie and Jean on that. Certainly with a kidney stone, when you hit it with a shockwave, it may not stay in your imaging plane if you're only working in 2D. So could you talk a little bit about that?
Yeah, so implementation, I think, is always going to be the challenge. We don't have the 3D feedback. And so that's where one of the groups I talked about specifically was looking at how can we tell in 2D at least whether our stone is targeted well, specifically for the kidney stones. So I hadn't seen that paper as much earlier, but it was very interesting because they were using the cavitation detection basically to monitor alignment. And so it works great if you have a very hyperechoic, very strongly scattering object that you're able to say, hey, that first scattering is what was very important for the targeting. And so you can say it's very well targeted. Great, you can use it, but that's a very specific application for the kidney stone. So I think it's a little bit harder if we start talking about other objects. So I don't know if that answered kind of where you were going or if there was something else.
Sure. No, thank you for that. Jean, any thoughts on motion, dealing with motion and potential for 3D imaging in the clinic? John, any thoughts?
Yes. We're dealing with that every day. So when we treat livers, the livers move, and when we treat kidneys, the kidneys move. So this is something that we need to take into account. So, for instance, it moves more the left kidney than the right kidney. Because the right kidney is sustained by the liver, but the liver itself, there are some segments that move less than some others. So when you have a lesion that is in the dome in segments 7 or 8, you know that it's going to be moving more than if you have a segment 2, segment 3, or even in the coded lobe in segment 1. So this is something that we need to deal with everyday life.
Mm-hmm. Great, thank you. Any other thoughts on implementation challenges? Konstantin? Unmute, please.
It doesn't make a difference because I was thinking rather than speaking, I think I think several implementation challenges remain precisely because of the issues that have been raised about the importance of having similar sensitivities, for example, to levels of inertial cavitation activity in sensitive structures. We need to think about whether there are any preferred or more robust ways of doing the post-processing for passive cavitation detection and passive acoustic mapping, so that even with equivalent detectors, two researchers working on the same application do not end up reporting a different result that has different implications for safety and efficacy. And I really like the comment that was made earlier. I think it was by Megan, building on something someone else had said about the potential significance of lower levels of something, and the comment that was made by Costas about the importance of relating it ultimately down to the very physical mechanism that causes the damage. Because if we can all agree that 3 magic units of inertial cavitation are going to shear a lipid bilayer enough in order to cause it to break, that actually becomes the absolute thing that we must make sure we have the sensitivity to detect. And if we can agree what the thing we must have the sensitivity to detect is, then we can make sure we have signal processing paths from detector to image that actually does it robustly across experimental setups, at least in the context of any single application.
Costas, do you have any thoughts about this? I mean, we are seeing controller algorithms in the InsightTech system, for example. But what do you think is coming next in terms of implementation for controllers?
I mean, we have to envision the systems that we have, and in that respect, I do absolutely agree with what John said, that we need MRI. But I'm not sure. I will also agree with what Kathy said, that ultrasound is good enough. So maybe we're going to think in a way that MRI is important pre and post operatively, and maybe 3-dimensional ultrasound, if it can capture the acoustic field of a therapeutic being, because we don't care what happens beyond that, right? If we are interested in monitoring the treatment, right? So we don't care what happens beyond where the pressure is high, essentially. That can happen for many different reasons. So if we 3-dimensional ultrasound imaging is able to capture the acoustic field, and in this workshop we are interested exclusively on microbubbles and cavitation. So if we're able to capture that, I think it goes down to defining some acceptable sensitivities. It goes down to embracing different algorithms that we cannot have the same algorithm. That will never happen. There are many imaging pulse sequences. There are many companies that will go forward and commercialize things. We cannot have the same algorithm, but we can have the ability, the notion of capturing a given field, having some sensitivity. And in terms of control, I think speed is going to be the absolute essence here, and being able to selectively, control different regions and different activity. So, but I think it's going to happen quite soon, and it's already happening.
There is one difference between planning and doing and targeting, because the ultrasound, when you're planning a treatment, you can use the ultrasound close to the skin of the patient, and you can see exactly all the qualities of the ultrasound, and it's very good to planify, and then you see the image beautiful. But then when you treat, you cannot do that. You have a distance, and this distance make that all the systems that we are now commercially available for follow-up these treatments, the quality of the images go down, and they are very, very low. And only very experienced people that know exactly what they're doing can monitorize very well these. And this is a challenging when you translate this to the clinic. So ultrasound, it's a good, but you cannot use it as you used to do when you treat or when you do a diagnosis of the patient, that when you treat. And this is something that using the ultrasound with more distance and with media that transmits the qualities of the control quality of the ultrasound, the same that when you are close to the target lesion. This is something that also needs to be considered.
Great, thank you. Kathy?
Sean, I was just wondering whether your colleagues use 3D ultrasound to monitor, for example, thermal ablation in the liver. Do they, I've been surprised here that I think our clinicians feel that they're so experienced with 2D ultrasound and with the ability to adjust the plane that they have not adopted 3D ultrasound in some of these applications that I might have thought they would have.
We're not using it, and our colleagues don't use it. No, it's here in Barcelona. It's been using only on GYN people that they do it for their when they monitor a pregnancy, but not in oncology. It's not used. So I have no experience.
Do you feel there are things that we could do to improve the presentation or the quality of the image, or is there a fundamental limitation that would encourage people to use it?
I think it's availability in terms of having it in the clinical setting. This device is more expensive than a 2D device. And, in a context of socialized medicine, of public medicine, what, cost, it's an issue. So this has not reached the main radiologists here.
Thank you.
Thank you both. And I have to say, so it's hardly ever a technical session anymore without discussion of AI and how it might change what we're doing. I think, Megan, you addressed this a little bit, and there are some questions coming up from the attendees, but I thought, just generally speaking, and since we're talking about developmental challenges for this technology to get to clinic, what do we think are the prospects for near-term implementation of AI-based techniques for cavitation imaging in the next couple of years? Megan, could you start us?
Sure. So I guess in your question, are you talking about the regulatory hurdles with implementing AI in some sort of controller, or are you just talking about the technical development to develop such an algorithm?
Actually, why don't we touch on the regulatory part?
So, yeah, we haven't gotten too far into it, but I suspect that there's a lot of challenges once you have a kind of driverless car, especially if you want to tie it back into some sort of control. So that may be a challenge that people will have to come up against at some point. Something I'm a little more comfortable talking about is, I guess, how the algorithms might work. So there's sort of two approaches. One would be to get an AI algorithm that is trained to reproduce one of the models that is used right now, but faster. So you can pick your favorite beamformer and you train it to just basically reproduce that. And you can sort of imagine how that would work. The other is to try and train the system to directly image and directly generate maps bypassing a beamformer, which ultimately could be faster, but maybe is less intuitive on how to implement. In terms of data sets for that, I think that there was a comment or a question about the fact that this cavitation is an inherently random process. And so how do you generate training sets? I think initially you can actually start with a lot of simulated data or fixed sources and start to just build the capacity to map a source and then build on that to add complexity. And certainly you can, if you're working in silico to generate training sets initially, you can develop stochastic models that kind of recapitulate some of the randomness of cavitation and then build out to work with more realistic data.
Any other comments? Yeah. John, I'm curious if there's been any AI-related work in histotripsy that you're aware of and what you think about that.
Not that I am aware of. Or sorry if you were talking to me or I am, skeptical of black boxes. So I haven't pursued it myself. I don't know if anybody else really has. One of the grad students in our lab at one point was trying to do something along those lines, but it didn't go very far. So,
okay, thanks. And to Joanne, you mentioned that especially with the ultrasound imager not close to the body, sometimes remote by several centimeters, that image quality can be a detriment. Is this something that potentially AI could assist with for treatment guidance?
Yeah, it could be, yes. But what we think on that is that we need to maintain and sustain the quality all along the process, the quality of the images. If this is, if this is obtained with that, perfect. Because the problem, for me, that I'm doing that from so many years, when we now go and see another clinician that is going to start doing that, for instance, in the multi-center European trial that we're doing now, and we show the device and the system to a clinician that has never seen something similar, you have to see their faces of disappointing when they see the lesion doing the planning, and then when they go and see it during the treatment, the quality drops dramatically. And this is, you can monitor, you can follow the treatment, whatever, but you cannot see the same quality. And they look at what this is not the same that we are used to do and to deal with. And this is something that needs to be solved.
I can make just one brief comment. I think I was always skeptical about AI, and because I always saying that our data are few and precious. But participating with the latest clinical trial on the broad brain barrier disruption with Graham Woodworth, I realized that in every patient, he's doing 32 at least targets. So if you just go out 100 patients only, you can have thousands of data sets. So I think there is a huge opportunity there to be able to do great things and give you the ability to post-process this data and come up with some new understanding about what's going on, and maybe establish some new thresholds.
Great, thanks. So as we're getting close to wrap-up time, I'm going to ask our panelists for some final thoughts. Before we step through each of them on that, though, in order to kind of try to see if we can build some consensus too, if we could get people to add their own comments, attendees to add their comments to the Q&A, either a comment about, here's what we think is resolved, or here's what we think is the key challenges, and then really invite those attendees to then upvote. We'd like to see if we can build some sort of thoughts there. I think we have over, 200 viewers right now. So I'm hoping if we can get large participation there, we should actually have sufficient data to maybe get a decent sampling of our field. So while attendees are doing that, Kathy, I'd like to go to you first for your final thoughts.
Yeah, thank you so much. I can only say that I'm really inspired by the group and by the set of tools and algorithms and capabilities that they've presented. I share Jean's thought that the field is in really good hands in terms of developing and translating these capabilities. So, but there are many challenges, and I'm not sure that we have iterated to final consensus on many of the points of the technology or the monitoring algorithms.
Fantastic. Thank you, Kathy. Let's see. I guess, Konstantin, do you want to hop in next?
I'm very happy to. I'd like to thank Kathy and John for the very kind comments. I mean, I also walked away from this thinking, wow, we have unprecedented technology and methodology to monitor, characterize, qualify cavitation in real time better than ever before. And I think now there is a rather painstaking piece of work that needs to involve all of us in using these new tools in their most standardized form possible, at least on a per application basis, in order to understand what it is they are telling us in terms of safety and efficacy thresholds. So now that we can map, now that we can localize, now that we can monitor, what are the things we need to be looking for on these tools in order to provide
a meaningful guide to clinical treatments from a safety and an efficacy perspective. And I think if we can do these two things, use the tools in an agreed format and go through the bioeffects investigations, then the field will move forward massively, and we'll be able to translate new applications to the clinic and satisfy the regulators, patients, and clinicians alike.
Great. Thanks, Konstantin. And Julie, you want to jump in next?
Sure. So I would summarize as pretty much anybody can go buy a passive cavitation detector these days, maybe even program an imager to get passive cavitation imaging done. So we have the data. Now the question is, what does that mean? How do you compare between the different instruments, even within the own lab collecting their own data? How do you compare between the different ways you can collect information on cavitation? And then from there, echoing what Konstantin and Kathy said, understanding what that means. How do we translate that to, is it injury? Is it good cavitation? Is it bad cavitation? Basically translate that into something that makes sense that will allow it to be translated into the clinic. And that's probably going to be very application specific, the last piece, but I think the first bits definitely can learn from each other in the different fields and use that together.
Wonderful. Thanks. Appreciate that, Julie. And then again, just a reminder to our attendees, go ahead and type in, your own thoughts on what this would be and look through what's posted there and get some upvotes. I'm seeing that we have some coming through. John, you want to give your final thoughts?
Yes, well, thank you again for making me being here and having the opportunity to getting inspired with you. And I want to, underline what has been said and also tell you that please keep on working hard, because there's a lot of work to do. And we are expecting this work. And then we need to know when we do an ablation or when we do a cavitation, if this is a full ablation or this is just priming. But this is not bad, because priming is a good thing. And if we do priming, we are stimulating somehow the immune system, and we can have excellent results. But we need to know the difference between both. And this is something that needs to be confronted after we have done the procedure. And then what happens with the different type of structures that we're dealing with. So we're dealing with tumors, we're dealing with normal tissue, we're dealing with ducts, metallic stents, plastic stents, vessels, and all that. And this needs to be very well characterized. And we need to know all this information in real time when this is happening, because we know it after it's happened. So we know it on 24 hours, but we need to know it when this is being performed. So thank you and congratulations. And
fantastic. Thank you very much. And Jonathan?
Yeah, thanks. The way I am thinking about this, one of the things that has come up in a couple of the talks that I think would really benefit everybody is managing all the data that comes in, especially for 3D localization. And I've spent an inordinate amount of time trying to optimize data transfer rates and all that to get these localization and mapping things happening in real time. And, I'm running up against the Ethernet bandwidth limit right now. But, data transfer is one aspect of it, but handling all that data to do the 3D localization in real time at rates of, I want to go at least 200 hertz, because that's what we deliver our treatments at. That's, I think, a little ways away. And, something that, would benefit everybody is increased processing and transfer rates. So, yeah.
Fantastic. Thanks. Costas?
Yeah, sure. I think they say the success is achievable goals, right? So we need to. I think we cannot really address in its whole cavitation and its bioeffects. But I would like to provide an example for brain that there are currently more than 20 clinical trials happening for different diseases. and there are 5 different companies that they are doing those clinical trials. I think we need to get to a point to come up with some metrics that will at least ensure that what is happening is also transparent to the society, and also is kind of like clear to the clinicians. So in that sense, I think it is a good time to start pull our knowledge together and come up with a way to provide some meaning on the acoustic emissions that are generated. Even if this meaning has large error bars, I think we need to go into this exercise now.
Great, thanks. And Megan, your final thoughts to wrap up the panel here.
I will just echo some of the comments on standardization. I think reproducibility is a huge issue in science in general, and we've had some amazing technology development that's occurred in parallel, and also building off of what different groups are doing in order to get where we are right now with some really great tools. But to make our work more reproducible and our connections between the signals and the bioeffects, we need to be standardizing how we're reporting, what sensitivities we have, so that, as was mentioned earlier, when somebody says, I see this signature before I see that signature, and somebody else sees it the opposite way, we can tie that back to what system, and we can determine which ones are most appropriate for the application area. And as Constantine said, we need to identify what is that hard metric between, some level of dose and the bioeffect we're trying to elicit, and that becomes our minimum, that you need to be able to detect that. So.
Fantastic, thank you. And I think what's great about ending there, right, is it provides the need for emphasis of collaboration within our community. But I think we've got the right community to do that. I think we're one that works well together. So with that, I'm going to go ahead and wrap up this panel session. We are a couple of minutes over. Again, I want to thank all of our speakers and all of our panelists for participating in this. And we will be providing a copy of this or a summary of this discussion and the comments that were upvoted early next week sometime. And Mike, do you have any last comments before we turn it to Fred?
Yeah, just a few, just to kind of think through what we've heard today. Some of the recurring themes I think that we're going to revisit, I'm sure, many times over. The issue of moving towards 3D imaging and how to handle all the data that goes with it. Calibration perhaps by different application rather than one size fits all. And standardization of methods and reporting. Now, those are my takeaways. And actually, I do want to mention that we're going to invite certainly all the panelists, the speakers, but also the attendees to let us know while all this information is still fresh in your heads. Let us know what you think. Please do send us a few sentences and give us your feedback on what you heard today.
I'll turn it over to Fred now.
Thank you. Thanks, everybody. Thanks to the speakers, moderators, panelists, and you, the audience, for the questions and the active participation. It was a very stimulating discussion. So as Kevin mentioned, the recording will be available early next week together with a summary. We will also try to address the question that we couldn't answer during the session when we will release the summary. And we will meet again next week for the third session of our workshop series about cavitation thresholds and dose that will be moderated by Megan O'Reilly and Elisa Konofagu, where we will discuss, among other, I think, this relationship between metrics and bioeffects. So thanks again. Have a good weekend and see you next week. Bye-bye.